Alrighty, so, oh good, the mic is working. So today we're going to cover a lot of stuff, because I remember the first time I saw the list of objectives, my gray hairs got grayer, because it's a lot of stuff to cover in warp speed, which is why I put that first lecture together, because I didn't want to spend this entire lecture doing pathophys. So what I tried to do for this one is combine things together as much as I could, so you could see common denominators. So we're going to cover very shortly embryology, just so you can figure out how normal people with normal families can have kids with congenital heart defects. Then we're going to talk about the nursing management of all of those things on the slide, talk a little bit about cardiac diagnostic testing. We want to talk about how we're going to do care for someone in shock or somebody with disease, CV disease, and then what kind of education we're going to do with parents. And we're going to do all of that in our fun-filled next 3 hours. Woohoo! These are my favorite websites that I go to for congenital heart things. I really like, the first one is Johns Hopkins, the patiented.org. The reason I like that website is if you pull up the picture of the defect, if you put your mouse over the defect, it goes back to a normal heart. And then when you move the mouse away, it goes back to the defect. So you can kind of see before and afters. And I think that makes it crystal clear. Cincinnati has just always been a great website. You know, Children's here in Dallas has a website. Most pediatric hospitals do, but I think these are the two that I have used for decades, and I still think they're the bomb.com. I really like this slide. I have no idea if it's a real one or they jacked it up, but I think it still gives you what you need to know. Cardiology is all about what's under the surface. That's why I don't like trauma, because everything's blood and gore and everything's out in the open. I like them nice and clean and closed up. And that's what you get when you're in cardiology. So let's go very quickly through embryology. I promise you this will not be on any exam. This is not, I would almost bet my life it's not on NCLEX either. But I think you just need to know enough to realize how this works. Okay? So, when two people love each other very much, so okay, you don't even know, ladies, you don't even know you're pregnant yet when the heart is developing. Okay, so especially if this is an unplanned pregnancy and you're out there having a good time with life, that's one of the ways that you can end up with kids with funky hearts. At 15 days of life, this is what your heart looks like. Doesn't look like much, right? But as you can see, within another week, it's already starting to form. And if you notice at the beginning, you don't, things are in weird places. And as you go along, things start to separate and move around, twist and untwist, turn and unturn. So what I'm trying to get at with this is that all it takes, let me go back real quick, is one time when it was supposed to untwist and it didn't. Or it was supposed to turn and, or unturn and it stayed turned, that makes a congenital defect. So most kids who have congenital heart defects is just a fluke of nature. The parents didn't do anything, it just is. So when you're looking, I think it's kind of helpful to see if you can find the different ductus, okay? Because this is inside mom, right? So remember, the lungs are deflated when you're inside mom. So you've got this nice little hole here called the patent foramen ovale, so that the blood can go from the right atrium into the left atrium, so it doesn't have to go to the lungs. You have a PDA, a patent ductus arteriosus, up here between the aorta and the pulmonary artery, so some of the blood can get into the lungs if need be. And then the third one is way down there by the umbilical cords, called the ductus venosus. Now, why am I saying all of these things? Because when I talk about some of the defects, these ductus come into play. That's why I bring it up. Otherwise, I wouldn't care too much. But so you can kind of see that it's just one of them weird fluky things that you're going to end up with a kid that's got your defects. And some of the defects, two of the defects that we're going to talk about, that PDA, that patent ductus arteriosus, and that patent foramen ovale, they're things that are supposed to be open in utero, and sometimes they don't close right away. And they become congenital heart defects because they should have closed and they didn't. They were very uncooperative people. Okay, so when you're born, right, they clamp the cord, they slap you on the butt and say, welcome to the world. So what happens is your lungs blow up. The pressures start changing immediately. So the right side pressures stay low like it's been all along, but the left side get high. And when the left side of the heart gets high, that PFO, that patent foramen ovale again, trying to find the little thing, it's a one-way door between the atriums. And as soon as the pressure on the left side gets high, it slaps shut, and that's the end of it, as long as everything else goes nicely, like it's supposed to. And we have that patent ductus arteriosus up there, the one that goes between the pulmonary artery and the aorta, and that one's going to close because the things that keep it open is low sats, because inside mom, the baby's arterial is our venous, okay? So low sats have kept it open. Now the sats are going up, right, because he's breathing on his own. The other thing that keeps it open is prostaglandins. Well, we just cut the umbilical cord, and that's where the prostaglandins were coming from. And pressures. And we just said that, left side's going up. So those are the reasons the PDA, the patent ductus arteriosus, should close. But then you got the little kids that are a little ornery, and they decide they don't want to. The ones we see that one the most in, and we'll get to that in a minute, are your preemies. Because, they're not fully cooked yet. That little thing on the cooked turkey thing that says you're cooked? It hasn't come out yet. So a lot of NICU babies have problems with the patent foramen ovale and the patent ductus arteriosus because, as far as their body's concerned, they're supposed to still be inside. So they're not ready to come. All right. A little bit of the same kind of stuff that you can, like I said, I like to show pictures in all different ways because some people like pictures with colors, some people like arrows, so I try to find things that had both. But I'm not going to go any further because I think I said enough about this. I did tell you it was going to be brief. Okay, so that PFO, that patent foramen ovale, where you see it between the atriums, that's this one. And the patent ductus arteriosus is over here. All right, the end. No more embryology. Told you it was going to be short. Okay, so let's talk about a normal heart. I really like, this is an adult learning thing that they had at, this is from CHOP, the Children's Hospital of Philadelphia. They had one of their cardiologists talk about hearts like a house. So I found this to be a very helpful thing when you're trying to explain congenital hearts to people who have absolutely not a clue what's going on. So this is just another way of looking at it, and I did put the website if you happen to like this version. We need to know normal so we can talk abnormal, right? So we all know 4 chambers, 4 valves, everybody's happy, we like all that. The superior vena cava drains everything from the head and neck. Where's the divider? The nipple line. Everything above the nipple line is your head and neck coming from the superior vena cava. Everything below that is your inferior coming back. Those are veins. Veins have blue things in it, except for the pulmonary veins, right? They're the only veins in the body that have red stuff, but they're still veins. So some of the defects may have those veins hanging out with their friends, the other veins, their cousins, instead of being where they're supposed to be. Same thing, arteries. We've got our aorta. We also have pulmonary artery, the only artery in the body who has blue blood in it. Same thing though, it's still an artery. And sometimes it's going to hang with its cousins in the arteries. So that's what I'm saying, if they untwist or don't twist the right way during development, that's when we start getting some of our funky defects. So I think everybody in here can follow the blood flow as it comes back to the body and through the different areas. Very helpful if you can remember the name of your valves. I know that when I was a nursing student, I could not remember why was one called tricuspid, so I knew there was 3 leaflets. Why wasn't the other one called bicuspid? Because it had 2. No, they had to call it a mitral. It's like, geez Louise. So it's called actually mitral because it's something about the Catholic Church and the bishop's hat. Yes. I'm a Catholic, I don't know that. Okay, whatever. Okay, so that's pretty much normal. What I also tried to do is, if you notice there's some slides that have blue stars on them, I tried to put blue stars on things that you might not need to know for your exam, but you need to know for real life. And, let's face it, you need to know a normal heart whether you're taking care of a kid or an adult. So if you don't know a normal heart, perhaps you need to go back to that other class called Anatomy Physiology. Okay, congenital disease, it means you're born with it, right? Acquired means you get it later. So these kids are all born with these things. And they're usually structural, and it just happens, and they stay that way. There aren't a lot of them out there. And as I said before, most of them are flukes. Greater than 80% of them, nobody knows why they have it, they just have it. Incidence, 0.7% of live births is approximately what you're going to get. So there aren't a lot of them out there. But I tell you, if you ever go to the cardiac floor at Children's, you get a very skewed look at life. Because I know I've been, the congenital heart kids I've been taking care of for decades. When I had my first grandchild, his PDA and his PFO, those two things that are supposed to close, didn't. And we had all kinds of issues. I'm like, see, they're all born that way. So it took some time. The other 4 grandkids weren't. So I finally said, okay, maybe not. We now have, actually, I need to go back and change it. We now have 2 million adults. Again, that's not going to be on a test. I'm not into numbers. But it's just an important thing to realize that there are very few adult cardiologists that will touch these adult congenital heart kids, which is why at Children's we have kids, notice I'm saying kids in quotes, on C8 who are of the age of 45 and 50 years old. So they go on that floor from day 1 of life all the way up to my age. Because most adult cardiologists, they want to take care of coronary artery disease and perhaps a valve. The end. They do not want to deal with these kids who have the most jacked up hearts in the world, right? And in the 80s, that's when we started having pediatric heart-lung machines. So that's when these kids started living. Before that, when I was in nursing school in the 70s, I learned 2 congenital heart defects. And so when I came back into peds in the 90s, I was like, where did all these come from? Well, they were all in the morgue when you were in nursing school. Because before we had the pediatric open heart programs, they died, period, the end. So the important thing to figure out with these kids is, because some of the defects are so in your face, you're going to recognize right away that there's an issue. They come out of mom and they look like, roadkill. You know right away something's bad. And now with the kids getting sonos, all kids getting sonos, almost all congenital heart kids are being diagnosed in utero, which is great because everybody can have time to get used to it. You can plan the surgeries. Parents understand what's going on ahead of time. Back in the 90s when I first started doing congenital hearts, almost none of them were diagnosed in utero. Unless mom was ancient, they didn't do sonos. I know I had 2 kids in my 20s, neither kid had a sono done. I wasn't considered high risk, no sonos were done. Who knew? Okay, so we need to find out what's going on with mom. What was she like? Did she have prenatal care? Hopefully she did. But did she have issues while she was in prenatal care? Notice the medication one. That's why we need to know, up front, this is a surprise pregnancy. What were you taking during your first trimester? I still remember, I think she finally died. We had a little girl who came to Children's all the time. Mom had super bad arthritis, and they were treating her with chemo kind of meds. And she asked her rheumatologist, she's like, I'm happily married, hint, hint. Do I need to do something different? And he's like, oh no, you'll never be able to conceive on all those meds. Her name was Sarah. And Sarah had more congenital defects than I care to talk about. She had heart defects, she had kidney defects, and it was all because mom was taking things that are bad. But, I felt so bad because mom asked, and the docs are like, no, you'll never get pregnant. One of the meds, lithium. We still have a lot of bipolar people on lithium. There's one congenital defect that's completely associated with lithium. So, if you're a bipolar lady and you're not trying to get pregnant and you have an oops, by the time you realize it's an oops, that baby's heart's already formed and you've already got your defect. So you can kind of see where I'm going with this. Other things does it run in your family? If mom has a congenital heart defect, the chances of child having a congenital heart defect go way up. It's no longer 0.7% of live births. Now it's like 30 or 40%. So it does increase drastically. So you always want to understand that. The whole sudden unexpected death, most likely it's one of those weird congenital heart things or that long QT, but it's something cardiac related. So if they've got a lot of relatives who drop dead one day and nobody knows why, we have to work up cardiac stuff on these people. As you can see, a lot of these things. Now, remember what I said, though, 0.7% of live births, because I'm going to make it sound like everybody should have congenital heart babies, right? So what we do when we get these kids, let's kind of go on. When a kid comes in with these symptoms, feeding problems, dysphagia, dyspnea, cyanosis, exercise intolerance. What is exercise intolerance on a baby? What? Right. Eating, drinking, right? All they do, right, is eat, drink, cry, pee and poop. Right. So exercise intolerance, you'll hear the mom say, I was feeding them and my arm was wringing wet because they were sweating. They ate like they were starving and then they fell asleep. That's exercise intolerance on an infant. But I'm here to tell you, checking them for a congenital heart defect is so far down the treatment rule-outs because only 0.7%. So they're going to rule out all the normal stuff first. You know, like, do they have an infection? Because kids are going to show the same symptoms if they've got gas, or if they're septic, or they have a congenital heart defect. All you're going to see is irritability and poor feeding. So they're going to rule out all the common stuff. You're going to hear people talk. Have you ever heard the expression, the zebra among the horses? Mm-hmm. We're going to get rid of all the horses before we rule out the zebra. And congenital heart is the zebra. Okay? Physical exam, failure to thrive is the big one. Because remember what I said, they eat like they're starving and then they fall asleep. They never get enough calories in. So we get them in, they're usually real puny, 5 percentile instead of 50 like they should be. They're just tiny little things. And I think the rest I already said. There are a lot of things I already said about the parents. Chromosomal disorders can give you a higher incidence. With Downs, depending on what literature you look at, somewhere between 30 to 50% of Down syndrome kids will have congenital heart defects. Downsers are also prone for leukemia. So a lot of our kids will end up on the HEMONC floor after they're done with us. It's kind of like God has pooped down the Downsers twice over, you know, not counting the fact that they have, you know, all the developmental issues that they have. Other defects that you might see, again, this stuff is nice to know. There's no star on this page. It's just the fact that usually congenital heart doesn't happen in a vacuum. It's one of those things that if they got this wrong, we start checking them for everything. Because if they have one issue, they probably have several. So when we figured out that they've got something going on with their heart, first thing we're going to do is have them go to see a cardiologist, a pediatric cardiologist. What is our role? This is kind of a, you know, if they, whether they get diagnosed prenatally or they're being diagnosed when you meet them, it's a very rough road for this family. They're going to go through mourning, especially if this was a little boy and Dad had already pictured him as the next Troy Aikman. Depending on the defect, some they could be. Other defects, not so much. So, you know, and you're going to get the blame game going on. I still remember, I tell the story, I'm a story person, I apologize. I remember when my daughter was born, I noticed a couple of her toes were like semi-fused to the first digit. And I sat there and I just beat myself up because I knew it was from all the caffeine I drank while I was pregnant because I worked nights. No caffeine, I'll kill people. So caffeine was required. And I beat myself up for the first, it was probably about a month and a half in. Before one day, my husband and I were laying on the couch together. And I happened to look down at his toe. And he got my elbow in his side, like full speed. And he's like, what did I do now? I'm Italian, so he's used to me yelling. And I'm like, your toes! And poor man, he has no idea what I'm talking about. Because I had not shared with anybody how upset I was that I ruined my daughter's toes. So it was pretty interesting to see, you know, that it wasn't, but I was blaming myself because my daughter's toes were weird. So the blame game is going to happen. You're going to have Dad saying to Mom, what did you take while you were pregnant? You're going to have Mom, who knows she didn't take anything, looking at Dad and saying, what do you got in your family history? Mm-hmm. So, you know, you've got to get them past that they need to understand nobody's at blame. This is a fluke. So a lot of that, and we're the ones that are going to have to deal with that because no one else is going to think about it. Because we're the psychosocial people, right? That's our job, along with everything else. The other thing is this the first kid? Well, if it is, then it's a lot easier. But if there's other kids at home, Then you've got the sibling rivalry going on. Not only did the older sibling have to deal with now sharing the parents, but they're sharing the parents who have a chronically ill child, perhaps, if it's one of the big defects. So there's so many, mom was expecting to go right back to work after the 8 weeks off. Now she can't find a daycare that'll take the kid because he's a medical issue. So those are the kind of things that we have to think about and perhaps get social work involved or whatever, because it's a big deal. And, I know that, thank God I didn't have any defect kids, because if I couldn't go back to work, I was the main breadwinner. If I hadn't gone back to work, we would have been, living in a pup tent somewhere. Okay, I don't know. Alrighty. I have no idea why the screen just went blank there for a minute. Know your community resources. There are parental support groups out there. I know Children's has one that meets, I think, once a month in the evening. But there are things out there for these people. So this is, if you're going to become a pediatric cardiac nurse, you're going to learn all this stuff because it is our responsibility. So wherever you work, so let's say you're an adult and you work on a GI floor and you see a lot of Crohn's patients. It is your responsibility to find out what kind of support's out there in the community for that Crohn's person. Or wherever you work, that's one of those things that you want to be not just the nurse, you want to be the nurse. And that extra step are the extra things. So it's really beneficial if you can find out what's out there to help them. Because, the isolation is a biggie, right? They're afraid their kid's going to get sick. They've already been told that if their kid gets sick, they're probably going to end up in the hospital even with a common cold. So what do? They're going to isolate themselves. I know I tell my parents of the big congenital heart defect kids when they take them home, you will not go to Walmart with your child until they are 2. You will not have family members over for the holidays unless you screen them at the door. I put the fear of God into them for a reason because, like I said, infections can bring them back in. So they have a lot more things to work over and to live with than the average. It's rough enough. Think about it. For those of you in the room who are parents, did you see any movies at the theater the year your child was born? Right? Or maybe you still don't. Well, now you're in school, so you see nothing. But it's just the idea that you're already somewhat isolated if you have a normal, healthy kid. How about people with chronic kids? It's a lot more. Very eye-opening when I first came to peds to see what they had to live with. Alrighty. So, I want you to turn to the person to your left, and I want you to tell your neighbor the top 3 things you just learned about your patient and family regarding congenital heart. You have 3 minutes. Alrighty, so let's get going again. So when we talk about our congenital hearts, it's all the hemodynamics. It's the blood flows, the resistance, the pressures, and all that good stuff. Keep in mind, my favorite corollary will always be blood is lazy. It will always go the path of least resistance. So it's always going to try and go from the higher pressure to the lower pressure. Whichever way that might be, that's where it's going to go. And it's not just blood, it's all fluids in the body. But for right now, with the hearts, we're just going to talk about the blood flow. Pressure gradients, we already said everything's lower pressure down the right side, right, if they're normal. The pulmonary side is always going to be lower pressure than the systemic side. We hope we don't have abnormal communication between them, but sometimes we do. So as I said, blood is lazy, and it will always go the easiest route. So I want you to talk about the difference, because we use words in cardiac called palliative procedures or palliation versus correction, okay? So I think you get the idea. If we're palliating, they are never going to be normal, but we're going to get it so it works, right? This is still going to cool the car. It just ain't quite right. So palliation versus correction. Some defects we can correct to normal, some we cannot. So the ones, I didn't spell function very well in that last sentence. So with palliation, so we have kids that are born with only 1 ventricle. Last I checked, we really should have 2. There is no ventricle store. So we can't go and buy them one. We don't have baby valve stores. So if they need a new valve and they're an infant, we still have to make do with what they got. So that's where we have a lot of palliation coming into effect. Other defects, just a simple hole, we can close it up. But some things we can't. So the way This is a very important slide. You need to understand the different types of defects. Okay, because NCLEX may ask you questions about this. I can promise you there's at least one question on the exam about this. You need to know, and it's funny because they've changed the names over the years. So when I was a new nurse and I was first learning about this in the 90s, all we did was talk about acyanotic and cyanotic. Which kids were blue, which kids were pink, and which kids were just totally messed up. The last two things outside. Then they said, well, that's not really explaining it well enough. You know, because that's kind of like being sort of pregnant. We need to make it much more clear. So we're going to say it's the ones that have blood flowing from the left to the right side. Then the other ones are going from the right to the left side. And then still, the messed up ones at the bottom. And then they decided, well, that's still not clear enough. So now we're going to talk about which ones have increased pulmonary blood flow, which ones have decreased pulmonary blood flow, and all the rest of that. If you notice, all the rest of the bottom hasn't changed. They're still just jacked up. But the top two are very, very clear to see. Increased pulmonary blood flow, decreased pulmonary blood flow is the way we talk about them now. So we're going to talk about them. I found this slide on the web that if you're a table person, you may find this very helpful. If you're not, don't look at it. Okay? Who knew that there was somebody out there named Creighton Abrams, and he's the guy who said, yes, question.
I do, I know.
Oh, you knew him? Oh, cool. But he's the one that said, if you want to eat an elephant, you start with one bite, right? And that's exactly the way it is with the defects, which is why I gave you the integrity. So you can take a little of it, maybe listen to all the increased pulmonary blood flow defects, and then turn it off and go somewhere else. And then come back later. And if you don't want to learn them at all, you won't break my heart. I think congenital hearts are the most cool things in the world. Okay, so the first one we're going to start with is our increased pulmonary blood flow kids. And they're the pink ones. So that's why I put some cute little pink things on there. So the ones we are going to talk about, and you're going to find that if you're going to see test questions about congenital heart kids, like for NCLEX, their favorite ones to talk about are either going to be the increased pulmonary blood flows or tetralogy of Fallot. And the reason tetralogy of Fallot is on everything, remember I said I learned one defect?
Yeah.
That was it. So since it's old geezers that write the NCLEX questions, we know that one. So that's why we use that one. So if you understand these and you understand TETs, I think you'll be in good shape. The other ones are helpful if you're going to work with cardiac kids. But if you understand these and the TETs, I think you'll be in good standing for testing purposes. Okay? I probably shouldn't say that, but I did. So so here are the four that we see. Here's pictures of all four of them. So the first one, remember we already talked about that patent ductus arteriosus. They connected the two things. Then we talk about ASDs, where there's a hole between the atriums. Notice everything is alphabet soup. Did you ever notice anything cardiac is alphabet, right? You don't have a heart attack, you have an MI. You don't have bypass surgery, you have a cabbage. Everything, and kids are no different. So we have ASD, BSD, PDAs, right? ABCs. So we do everything by the alphabet. So we have small holes, or holes between the atriums. So there's that nice little septal wall. Instead of being nice, it looks like Swiss cheese, hopefully with only one hole. You can also have holes in the ventricles, same thing. And then my favorite, the AV canal, where there's a hole in the atriums and a hole in the ventricles. And instead of having a tricuspid valve and a mitral valve, you have a common valve with all the leaflets together. Oh. Yeah. Remember I said no valve stores, so surgeons have to figure out a way to make that into valves. Good luck with that. Yes, question?
You said no, these four, and what was the other one?
Tetralogy of Fallot, which will be the next one we talk about after these four. Okay, so whichever one you look at, it's going to be the exact same issue. So I decided to find like the poster child for each defect. So I decided for this one that I was going to show you the AV canal. So as I said, this one is like all of them put together almost. So the first thing we see is a hole between the atriums. And notice how the blood is flowing. Remember I said it's lazy. It's going to go from the right to the left. Well, excuse me, the left to the right. Same thing, there's a hole between the ventricles, and then we have the jacked up valve in the middle. So if I have too much blood flow going backwards, I have increased pulmonary blood flow, what is that going to do?
Back up in the lungs.
It's going to back up in the lungs. Okay, so here's that pted.org. So here's my AV canal, here's my normal. Okay, a little easier to see when you can just see it both ways? All right. So,
Is that piece from the cross supposed to be?
it's all the valve leaflets there, and they're leaky as all get out. So, preoperatively, if I have increased pulmonary blood flow, that means all of that red blood's going back to the blue side, and the poor pulmonary arteries are taking all that blood to the lungs. So what are we going to see? We're going to see number 1, number 2, and number 3, congestive heart failure. So these poor little kids are going to look like CHF. And did you not have a CHF lecture in Adult 2 recently? Okay, so you're pretty, and you know what, CHF in kids and CHF in adults, not that much different. And we've got some more of that coming later on in the lecture. Failure to thrive, right? They can't eat. They get too tired, they can't breathe. And their sets may suffer because of the CHF. Just because if the lungs are full of fluid, they're not going to oxygenate as well. Okay, then we fix them, and we get them back post-op. Okay, so the first thing I want you to ask you guys, what are common post-operative problems for all surgical patients? I don't care if you're 1 day old or you're 100 years old. What do we worry about post-operatively in patients? Infection, hemorrhage, pain. That's good. That's good enough. That's because those were the ones I was listening for. Bleeding, infection, pain. Because if they're in pain, they're not going to do the things they're supposed to, right? So they can end up getting pneumonia because they're not deep breathing, coughing. You know, kids are the same way, and they're infants. They don't understand why it hurts, which means we have a tendency to give a lot of pain meds to kids because we have to figure out they're in pain in other ways, right? We use that FLACS scale for the infants, the nonverbal scale, or we use the FACES for the older kids. So with procedures, just real quick, where do I put this here? Common cath lab problems that all cath lab patients have. I don't care if they're 1 year old or they're 65. What do we worry about post-op cath?
Immobility.
Immobility. What do they get at the groin? They can have bleeding. They can make hematomas. Okay. The one thing, I don't know anything about your adult questions on your exams, but if there's any cardiac caths, the one thing you always want to do with a cardiac cath kid or adult is turn them on their side, log rolled, to see if they're hemorrhaging. Because, right, if they bleed from their groin, do you see it? It pools under them. And I can't tell you as an adult cardiac nurse how many times when I've rolled a patient, they were sitting in a puddle. Because the trickle would go right down the inguinal area. You didn't even know it was there. And you turn them over and you're going, ee, because there's so much blood there. So post-procedure, so if I have to worry about bleeding, and what about below that, on that leg? What do I have to worry about? Right, pulses, because they can clot off that leg, right? It can happen in kids, too. Okay, so back to our increased pulmonary blood flow kids. Some of them will be fixed in the cath lab with just procedure. Some of them are going to need the OR. But we're just going to keep in mind what's going on with these kids. If there's a hole, they're going to fix it. If there's a problem with the valve, we're going to try and reconstruct the valve so it's no longer leaky and doing as good a job as it can. So if it's not leaky, it's called continent. Kind of like incontinent for peeing, right? So a competent or continent valve, actually I think it's more competent. A competent valve is the one that's not going to leak. And with these kids, they have a lot of problems with that. And with these procedures, with all of your increased pulmonary blood flow people, these will be corrective surgeries. These kids should end up with a normal heart, except for possibly some of those AV canals with the valves. But for the majority, the ASDs, the VSDs, and the PDAs, they will be completely normal when their procedure is done. Okay, which is kind of good. So, since we were fixing holes and fixing valves, the post-op complications are going to be that they continue to leak. So instead of having a complete septal wall that doesn't have a hole in it, maybe around the sutures it's still oozing some blood through. Other things that it could be is, what part of the heart did they cut? Yes,
Can you repeat that? So the ASDs, BSDs, and the ACDs are the ones,
PDAs,
oh, the PDAs?
PDA.
But not the.
Right, the AV canals, those are the ones that may still have some valve issues.
Okay.
Okay, but the ASD, VSD, PDAs are completely repairable. Now, one of the other things you want to think about is when they go in to fix the heart, what part of the heart muscle did they cut through? So let's say they were going into the atrium, and we cut through the atrial wall. What lives up there in the top of the atrium? Yes, they know, right. And at the bottom of the atrium is your AV, right? So what's the chances that you could have some sort of a heart block? Right, like a junctional rhythm, something along that line, pretty high. So you always want to think about, if you cut through a ventricle, they get very irritated, and you'll have PVCs and VTACs sometimes. It really depends on the skill of the surgeon. So, you know, we're pretty lucky at Children's, and Medical City's also got great surgeons. Actually, so does Coast. I mean, this Metroplex area, we've got good pediatric heart surgeons. We don't run into problems. But I have seen some Dr. Quacks that you don't know what you're going to get in the post-operative. We used to have one at Children's years ago where we kind of ran out of town because his patients, you know, were always super unstable, even for simple surgeries. Very difficult to work with. Okay. Doing it again. They're like, man, I was just comfortable. So this time I want you to stand up because I know you're starting to get a little sleepy because after all, it's been a fun-filled 45 minutes. Okay. When we start talking about when the blue blood goes to the red side, that's when you get kids that are starting to turn blue. So now we're going to talk about the defects that decrease pulmonary blood flow. So if the blood can't get to the lungs because there's something going on that's stopping it from going to the lungs, blood's lazy. Even though the left side is higher pressure, it's still going to be easier to go there than somewhere else. So that's why it's going to do the blue kid, the decreased pulmonary blood flow. Right, it did that again. Okay, so this is where we get our very famous tetralogy of Fallot. Any of you guys out there, movieaholics from HBO? Years ago, there was a movie called Something God Made. And what's his name? From all the Harry Potter movies was in it. Alan Rickman?
Yes, Alan Rickman.
Yeah. And it was the story of the two doctors who figured out how to fix tetralogy of Fallot kids back in the 40s and 50s before heart-lung machines came about. It's a great story if you have, when you graduate and you have some time. I'm going to look it up. It shows up on HBO every so many months.
It's called Something About.
Something God Made. Pretty cool. It's a one-time movie, though. You know, it's not one you're going to watch 25 times over. Okay, that's why I put the blue star there. Tetralogy of Fallot is one that they really like to talk about. Tetralogy means 4. That means there's 4 defects in one. They got their money's worth, didn't they? Okay. The other one would be tricuspid atresia. Again, here's that same table. I just keep moving it around. So our poster child is going to be our TET. So something you're going to hear me say, not as much here as I think I might have said it a little bit more on integrity, is when you're working with congenital defects, if there was no blood flow while it was developing, it didn't grow. So I like to use the expression, no flow, no growth. So in utero, since they had some sort of a blockage, at the beginning of the pulmonary artery area, and things did not get up there, you're going to find the pulmonary arteries are very small. So the 4 defects for the TET is you're going to have pulmonary artery stenosis, narrowing of the pulmonary outflow tract, however you want to phrase that. You have a hole between the ventricles, so a VSD. Your aorta is sitting right on the fence between the 2 ventricles. Should I be in the right side? Should I be in the left side? I don't know, I'll sit in the middle. Hence the name overriding aorta. It sits between the 2 sides. And then the 4th piece is the fact that in utero, since this was blocked, even what little blood did come down from the right atrium to the right ventricle, the poor right ventricle was working really hard, so you already have hypertrophy of the right ventricular wall. So it's thick. So the four things you see for a tetralogy, you see the narrowed pulmonary outflow tract, the pulmonary artery outflow tract, you see the VSD, you see the overriding aorta and the right ventricular hypertrophy. As I said, I would keep this one in your mind for NCLEX too. If you don't keep any of the other ones, this one's probably a good one to have. Okay? So let's see if I can get this to work. Oh, that didn't work the way I wanted it to. I really just hope, you know, let me end it real quick, get to that slide and play it. I apologize. It worked just fine in front of my computer.
Normally, blue or low oxygen blood returns from the body and is pumped out to the lungs. Red or oxygenated blood.
Hold on. You know, there's always something that makes you look stupid when you do these things.
On the bottom right-hand corner, if you click that icon, it should
This
take
one?
you back.
Thank you.
Lion.
I wish I could give you points for it.
Spends too much time on the computer.
Or low oxygen blood returns from the body and is pumped out to the lungs. Red or oxygenated blood returns from the lungs and is pumped out to the body. Tetralogy up below is made up of 4 problems that result in not enough blood flow to the lungs. Complete surgical repair consists of removing the pulmonary valve and opening up the narrowed area out to the lungs by using a patch material. Also, the hole between the bottom chambers of the heart is closed. This allows separation of red and blue blood and augments blood flow to the lungs. Unfortunately, removing the valve allows leaking of blood backwards, which over time results in stretching and weakening of the right ventricle.
But they'll worry about that when the kid is older. Literally, they will worry about it later. Because when the kid is older, the valve store is open. Right? We have fake valves for adults. So they'll worry about it later. TET spells are another thing that they love to test about. So I call them a TET spell because that's the lay term that we use. But hypercyanotic spells, and I know for a fact there's a question on the exam about this one. So these are things that we get prior to having the TET repaired. And we don't like to repair these kids very early because remember, your hand, your heart is the size of your fist, right? So if you're talking about a newborn, how big is a newborn fist? Jumbo olive, if you're lucky. Okay. Do you really want to do major reconstructive work in a jumbo olive? Sometimes we have to. We don't have a choice. With these kids, we usually do have a choice. But the thing that you want to know about these TET kids are that once the blue blood starts really spilling over, so all it takes to get a hypercyanotic spell is to get the kid upset. So we've got an unrepaired TET that we have to stick for blood. Okay? Mom has to leave. That's going to get them upset. If it's a toddler especially. So, you know, anything that's going to get them upset is going to get them working harder. And think about when you get upset, you start working yourself up. And one of the things that's going to happen is they're going to get a little hypertensive, a little tachycardic, which is going to increase the amount of blood going from the right side to the left, make them bluer. When you get hypoxic, you vasoconstrict. When you vasoconstrict, you have less blood perfusing, which puts you into, remember, Krebs cycle? Anaerobic metabolism, right? So anaerobic metabolism has the byproduct of acid, which makes you more acidotic, which makes you vasoconstrict more. So you can see how once a TET spell starts, they just slowly go down the tubes. Sometimes not so slowly. And they're getting bluer and bluer in front of you, and you're going, OMG, what am I going to do now? So things that we do, first thing we're going to do for these kids as the TET spell happens, if we're in a hospital and we're lucky, we can give them some oxygen right away. But the next thing we have to do is we have to decrease the amount of blood flow back to the heart. Because if we do that, then maybe less of the blue blood will go to the red side. So if they're infants, you heard them say knee chest. You literally bend up their knees and push it to the chest. So they're all, in a fetal position. Because think about it, if I put the knees to the chest, which I can't do anymore at my age, I'm going to decrease my venous return. Older kids that are unrepaired, they're the ones that'll just stop playing and they'll get down and squat. Squat does the exact same thing as the knee to chest. So infants, we knee to chest them. Older kids will squat themselves. I went on a mission trip a few years back for a cardiac mission trip. And we were repairing like 14-year-olds' tets. And they had fingers that looked just like this. The amount of clubbing was impressive. And Mom would tell them, well, she told the translator, she didn't tell me nothing, I don't speak Spanish. But she would tell the translator about how the girl would squat when she got upset or when things were not going well. Yeah. So I tell you, mission trips are pretty cool things because you change their lives. I don't care what kind of a trip it is, whether it's cardiac or whatever, you change their lives. So, things you want to know about hypercyanotic spells, knee to chest or squatting. Give them some oxygen, calm them down. So if oxygen isn't enough to do it, the next thing we give them is morphine. You go, morphine? They might not be in pain, but what does morphine do? It's going to make them relax, right? And what else? What is the side effect of morphine? It will vasodilate, right? Don't we have to always worry about blood pressure dropping when we give morphine? So can you see how vasodilating would help? Give them oxygen, because what does oxygen do to your pulmonary bed? Right? It vasodilates your pulmonary bed, only your pulmonary bed, but it'll vasodilate that. So, and it increases your oxygen level. So, TET kids, we have to know how to fix a TET spell. Knee to chest, some oxygen. Things that we can do to prevent a TET spell, we give them Inderal, propranolol. Don't give it to very many other people, it's a very old drug, but it really works for these kids. Slows down the heart rate, increases the squeeze, and vasodilates. Everything we need.
So you said Inderal and...
Which is propranolol. I gave you, you need to know your generics for NCLEX. NCLEX has no trade names. So I gave you the word Inderal because I think you might recognize it more, but propranolol is the name you need. Okay? I threw this up here because it's the only defect you can actually diagnose, or not really truly diagnose, but you can see it on x-ray. Normally when you look at chest x-rays of a cardiac kid, are you going to be able to diagnose a defect from an x-ray? Of course not. An echo, that's a whole different story, but not from an x-ray. What the x-ray is going to show you perhaps is an enlarged heart. It may show you in a lot more fluid, right, CHF kind of stuff, but you'll never be able to diagnose a defect from an x-ray. But this one's got a little bit of a, because you're seeing the right ventricular hypertrophy is what you're seeing. Okay, so the case studies are not in the same order as my lecture. So now we're going to go, for those of you who are you who got assigned case study number 2. So we're going to hopefully, you can help us with this. So by the way, these are kind of like real patients that I've taken care of over the years. I just kind of mashed them all together. So Susie Underwood was diagnosed in utero with a TET. She comes into the clinic today. She's 2 months old, which means she's probably not fixed yet. Okay, so see, cardiologist is hoping that she can be repaired around her first birthday. So these are her vital signs. So anything in those vital signs got you concerned about anything?
Pulse, respiration.
For a 2-month-old?
No, the respirations are good. It's the pulse ox.
Pulse and respirations really are, they're not panties in a wad kind of vitals.
89%. Sorry.
Okay, so the 89%, you've never heard that before?
I work in adult,
Oh,
and so my mind goes,
right. See, what the nice thing about working in peds is we have these delightful little badge buddies that have saved my life more times than not. They give me vitals by age, so I don't have to know. And actually, I use that when I pull those. But yeah, you said SAT of 89, right? That isn't normal, is it? That's a B+. We don't like B+ SATs. We like A+ SATs. So that SAT is telling me that she's got a little bit of right side to left sided shunt. She's got some blue blood going over the red side. How about her weight, 4.9 kilos? Did anybody look that up? That's pretty low. Remember I said a lot of these kids, they're scrawny because they don't have a very good exercise tolerance. They don't eat very well because they're always a little on the tired side.
So you're saying that the 4.9 is low?
It's a little on the lower side.
So 10 for 10 pounds for
Oh, okay. All right, sorry. I got
no,
the mixed
I'm
up.
asking, like,
That one's not bad. You're right. It's the next one there's another one that's really
But
scrawny.
the respiration is okay?
It's a little high, but for a 2-month-old that's an unrepaired tet,
That's normal?
it's going to be normal. You're going to find in the land of unrepaired cards, or any of the chronically ill children that have any, like a cystic fibrosis kid, anything like that, you're going to get really attuned to what norms are for them. So when we learn about pediatrics, right, first thing we learn about what are normal vital signs. But then in real life, you have to take it one step further. What are normal vital signs for this kid? Because this kid isn't quite normal. So today, this kid's vitals that might be jacked up are normal because that's where they are. Once the heart is repaired, that's when I'm going to expect things to be a little different. So for this kid, other than the SAT being a little low, the rest of them aren't all that bad off. Okay? So mom tells the nurse she's confused why Susie is on propranolol. What would you tell her? We already kind of talked about
yeah,
that.
it's gonna help with prevent a spell.
Right, so we're hoping that the propranolol will prevent TET spells. Good. While being examined by the provider, Susie gets upset and starts to turn blue. So what are we going to, why is she turning blue?
She's getting upset.
Because she's getting upset. So how are we going to relieve this problem?
Needle
Needle chest. Right. Oxygen, because if we're in the office and it's a cardiac office, I'm betting they got oxygen in there.
morphine.
Okay, so what do we need to teach mom about these specs?
Teach her what to do when it happens.
Right, teach her about the knee chest, teach her about trying not to get the kid upset.
Yeah.
I still remember taking care of a kid who came in to have her TET repair done, and her cardiologist had told the parents, don't let her get upset or cry. This kid was a year old, and they never let her cry. Do you want to talk about the most spoiled, rotten girl? I mean, my hand was itching because, and so then we had to teach the parents, okay, she's repaired now, let her cry. And I'm sure they went home and had a month of pain and suffering trying to break that kid. Because, if the kid cried, they picked her up. They did whatever it took to keep her happy. That was a rough, rough time for those people. Okay, so tomorrow Susie's scheduled for a cardiac cath. What does a cardiac cath tell the medical team? What are we going to learn about in the cath lab about this kid?
High risk.
What it actually does.
What do we see in a cardiac cath?
Stenosis. Oh.
It's going to tell you what is the oxygenation level within each of the chambers.
Mm-hmm.
So it's going to tell you how much of the blood is shunting over and
Right.
how desaturated is really the
So it's going to give us the sats in all of the 4 chambers. It's also going to tell us the pressures in all of the 4 chambers. They're going to be able to shoot dye in and see how well the ventricles are contracting. Is enough blood being extracted, is being ejected from the ventricles? So it does a lot of things, right? Because when they do a cath, they put catheters in the right side of the heart and into the left side of the heart. They shoot dye so we can see function. They measure the pressures. They look at the sats. So it doesn't matter if your cath is being done to a child or being done to an adult. They're still doing all of those things. The additional thing they're doing with the adults is checking out the coronary arteries. Because we don't really check the corns on the little kids unless we know there's an issue. So, but I mean, cats are cats. It might be a ye little thing, but we're still doing pretty much the same procedure. And they're going to give us the same info. Okay. What is the preparation for a cardiac cath for children? What do you think we're going to do? So if she's scheduled for 8 a.m., what are we going to do in the hours beforehand?
Yeah.
They're going to be NPO after midnight. If it's a real tiny baby, it's only for 4 hours. They're only NPO for 4 hours. NPO for food after midnight, but for like breast milk or formula, 4 hours. You have to do it a little bit different with the little ones. What do the parents need to know to prepare their child for the procedure?
Or what you just said about not to give them anything.
Right, they need to know about the fluid status, the MPO status. They also, the kid might say, where are we going? What are we doing? So you've got to be able to find a way to say it in words, that age group. This is why growth and development never goes away in pediatrics. Because I can't tell a 2-year-old what I'm going to tell a 12-year-old.
Right.
And I can't tell the 2-year-old 3 days before the surgery or procedure, where I can tell the 12-year-old a week before. So, you have to keep all of your Piaget, your Ericksons, they really do have a place in every single thing you do in pediatrics. So it will haunt you for the rest of your peds career. And don't forget about it until you've passed NCLEX. Then if you don't go into peds, you can press erase. But not really, because don't we have Piaget and Erickson all the way up to your dead?
Yes.
Right? Because I'm getting to the point where I'm getting to that last senior citizen one, where I'm going to look back at my life and see if it was good or not. Not quite there yet, though.
So
Okay.
what would you say? We're gonna take a picture of your heart?
Yes, we're going to put you in, because most of these kids have had some sort of an x-ray done already. So remember when we took a picture in that fancy room? And the nice thing about peds, they put them under. They're not just sedated. Anything, MRIs, CAT scans, cath lab, they're under general anesthesia. Because you can't get a kid to lay still until they're probably well into school age.
Yeah.
I'm not even sure my 10-year-old grandson would lay still for a cardiac cath.
Yeah.
And you don't want them doing this while you've got these things in your leg,
Yeah.
So you need to prepare the parents for full anesthesia. They need to know, we're going to put a breathing tube in, we're going to put them out. They're going to have to go to the recovery room when we're done. Plus, they still have all the groin stuff and the pulse stuff that we would normally look for. Make sure the parents know about the bleeding, to watch for bleeding under the leg. Kids have great circulations, but they can lose pulses in their leg after a cath. So it's still all the same things that we would teach an adult, plus the additional stuff with the kid.
How long do these procedures last? Like you said, like for the little itty bitties, it's only 4 hours, that you would do MPO or whatever. So how long do these procedures?
It's going to depend on what they're doing, an hour, 2 hours.
Okay.
They're not that long.
Okay.
Most cardiac caths aren't, unless they're doing procedures during the cath.
Oh.
Then they could last a little longer.
Okay.
So we have cardiac anesthesiologists that specifically do cardiac kids. And they're very comfortable, because I know we have 2 that just are in the cath lab. And they do all the anesthesia for the cath lab. And then we have other ones that do all the cardiac surgery. You know about that. Just for that reason. Okay, so I think we answered all that, didn't we? Okay. So, preoperatively, for the decreased pulmonary blood flow, we talked about the TET spells. Again, we have failure to thrive and oxygenation. Are you starting to see common themes? Some things never change, right? And so another thing is, so if I got a baby that was born and we had already diagnosed in utero that they had tetralogy of Fallot, we know that we want to get this kid up to about a year of age before we repair him. So one of the big things, since failure to thrive is a problem with these kids, we need to feed and grow them. I feel like a gardener. We're going to feed and grow your child. So instead of putting them on regular formula or regular breast milk, we're going to give them fully loaded. We're going to increase the calories. Okay, right? Because if you buy Similac Enfamil at the store, it's 20 kilocalories per ounce. And you're like, who cares? You really don't. That's cool. We can bump that up to 24, 27, even 30 kilocalories per ounce. We can put stuff in breast milk to increase the caloric of that too. So we're going to give them, kind of like if we were drinking Boost or Ensure all day, we're going to do the equivalent of something like that. We want to bump up their caloric intake because a normal kid should have somewhere around 100 calories per kilo per day. We're going to give these kids 125. We're just going to give them more because we want them to get as bulked up as we can, as fast as we can, so they can tolerate the surgery. Okay?
So this is just before the surgery.
And usually it takes a while after the surgery, unless it's a corrective procedure.
Yeah.
Then they can usually go to normal afterwards.
So would you use their weight and stuff to see as far as if they're at where they need to be before the procedure?
Right. So they're starting to look, about the right weight.
Okay.
That's when they'll take them to the cath lab to see how things are looking inside. Everything's looking good. Then they'll take them to the OR.
So they're gonna have like a Mickey button and oxygen, more than likely.
Probably no, no, neither.
Okay.
They're only gonna need that stuff if they really can't tolerate. What they'll do instead is they'll just give them more calories per ounce of formula. So they'll still be eating the same amount as everybody else. It's just, instead of drinking milk, they're drinking a milkshake. Not really, but I mean, that's, the calorie-wise.
Yeah.
Just because you want to get more in them, yes.
This is usually fixed at 1.
Somewhere between 9 months and a year. And every defect's going to be slightly different, and it's surgeon and cardiologist preference. So what they do is they have rounds once a month on a Friday afternoon. I never could figure that out. Where the cardiologist will present their patient to the surgeons. And the room is full of all the pediatric cardiologists and the pediatric surgeons, open heart surgeons, and they present the kids, and they decide from there what the plan of care is going to be for this kid. And the surgeon, because they never truly have like a plain tetralogy of Fallot. They'll have that plus a little bit of this and a little bit of that. So the surgeon will say, well, I think we could do this or that. And the cardiologist will say, well, when do you think you can do it? And they'll go back and forth. It's a very collegial place. I was very impressed sitting in on cardiac rounds because they really, because there are some kids that have so much, they have like, fruit salad mix-up for a heart. They've got so many defects at one time that they'll sit there and they'll look at the cath and the pressures and all of that and try and figure out what they can do for the kid. And every now and then we get one we can't do anything for. And they just go home and get loved until they go to God. Doesn't happen that often, but we still have a few. Okay, so again, with the decreased pulmonary blood flow, close the holes, fix the valves, and we're hoping that they should have pretty much normal stuff post-op. This is pretty much a corrective, but that right ventricular hypertrophy. Remember what the surgery, the video clip said.
Yeah.
You can still end up with issues in that right ventricle. And if the right ventricle is really, really small, no flow, no grow because of the tricuspid atresia, then we're going to do completely different types of surgery, similar to the big one that we're going to talk about at the end, the hypoplastic left heart. So again, post-operatively, we could have holes that remain leaky, valves that remain leaky. We've cut through the ventricular wall, so PVCs. There's a rhythm called JET, junctional ectopic tachycardia, that you only see, I never even heard of it in adults. It seems to be a PD thing, and I wouldn't look that one up because it's something you're only going to see if you go and start working with the TED kids. But they can have weird arrhythmias post-operatively. And they could have this problem with pulmonary artery hypertension. You heard of PAH? Vaguely somewhere on a commercial on TV that you got it if you took fen-phen, right? And they're suing.
Is it the same, almost the same thing as just pulmonary hypertension?
Mm-hmm. Same thing. Yep. So they could have PAH problems post-operatively. So while we're on PAH, I thought I would just bring it all up. And I'll bet I'm going to have problems playing this one too. Maybe. And mind you, these things always work when you practice them on your own.
What did the JET stand for?
Junctional ectopic tachycardia. Well, so much for this one. Evidently, it's not here. I will find the link and I will have it, I'll post it on Blackboard, the link that explains what PAH is, because I think it would be helpful. Because there's different types of PAH, and we do see quite a bit in kids, and you'll see it also in adults. But in kids, it's something that can happen at birth. Because when we cut it, remember what we said earlier, and you probably have said, that was an hour ago, I don't remember. That when they cut the cord and the right side of the pressure stay low and the left side go high, sometimes it doesn't work right. Because the dominoes are supposed to fall in a certain order, where the pressures on the right stay low and the pressures on the left go high. Sometimes the ones on the right stay high, which can be really jacked up. We don't like that. And then because the body at that age is very accommodating, it'll start making permanent changes to the vasculature in the lungs to accommodate those high pressures. And the next thing you know, your body is so used to it that it stays. So this pulmonary hypertension is now a permanent kind of a thing. So it can happen in the neonatal period for no reason known. It can also happen short term with our congenital heart kids. And there's certain ones, and these alphabet soups, we'll get to, the first two you already talked about, AV canal and the hole between the ventricles. This one we'll talk about in a few minutes, that's your truncus. But what happens is they were used to all that increased pulmonary blood flow, then we fix the heart and we cut the blood flow down to normal. And the arteries in the lungs are going, wait a minute, I'm used to all that increased flow. I can't handle this. Where is it? So I'm going to start vasoconstricting and making my own pressure to make up for it. And the video clip explains it much better than I am. But the thing is, what's nice about the post-op ones is the body will acclimate back to the lower pressures, and they usually will go back to normal and everything's peachy. The permanent ones that we see with the ones that are unrepaired, I remember getting a kid who came to us from third world country, somewhere in Central America. I cannot remember what country it was. But his VSD, the hole between the ventricles, had been there so big and so long that he had permanent changes to his pulmonary vasculature that he was irreparable. Because his PAH was so strong that if we tried to fix it, he would have vasoconstricted up his lungs to death. And that was a very heartbreaking thing because, they finally saved up the money to come to the States to get fixed, and it was too late. The only thing that they could offer was a heart-lung transplant.
How old was the kid?
8, 10, somewhere in there.
Years old?
Years old.
Oh, okay.
What sort of life expectancy do those kids have?
It depends on if they can afford the meds. We've got some good meds out there now. They can do pretty good, and they might, they should be able to make it to adulthood and do okay, depending on how severe it is and is it getting worse. That's why we love that Viagra stuff. Viagra was not made for men. Viagra was made for pulmonary hypertension, and that's what it works on the best. I understand there's other things out there. Okay, PPHN, which is a type of this is where the dominoes don't go the way they're supposed to when you're born. The pressures don't go down. I'm going to kill them. The pressures don't go down when they're supposed to. So you end up with vascular changes.
Do you need anything?
So back to this PPHN. This is where when the pressures are supposed to, go high on the one side, low on the other, it just for some fluke of nature doesn't happen. And they just have this persistent pressure that doesn't go away. And I can remember taking care of these kids, and it was very, very sad because there was nothing. We don't do heart-lung transplants at children. We only do hearts. So we were sending most of them to Michigan because Michigan's one of the few places that does heart-lung.
For
kids.
For peds. Oh, okay.
For kids, yeah. Adults, there's lots more places. But when you're doing kids, it's a little bit less.
Where is that in Michigan?
I don't remember. I just knew that they were sending them to Michigan. And that was, all I knew is they NBH, not be here anymore. Because they're very, very frightening to take care of. Because if they have an attack, a crisis, a PAH crisis, they can code and die on you in less than a minute. Because I had somebody, thank you God, they didn't code, but they PAH'd on me. I suctioned them and got them upset when I didn't follow the correct procedures. And it was the middle of the night, and everybody must have went to breakfast because I'm screaming I need help and nobody was coming. And my patient sat it to 36. It was the most religious experience I'd had, begging God and praying as I'm bagging. The kid did come up, but it took about 5 minutes.
Wow. Longest 5 minutes.
Yeah, it was the longest 5 minutes of my life.
Wow.
So, what I'm trying to get is the PAH can make the pulmonary vascular disease happen. So sometimes, And if you notice, there's no blue stars on these things. So this is nice to know, but you don't need to know. But if you're going to be taking care of adults in cardiac and they have PH, pulmonary hypertension, this stuff can kind of be helpful to help you understand it a little better. So, as it says, it's irreversible, heart-lung transplants are required. And I don't care if you're talking 1 month or 50 years. It's the same thing. Because with the changes, you have to get rid of both organs. One and not the other won't work. Okay. I kind of mentioned the unrepaired. Another way of looking at it, because remember I said I like to show you different options. So you can see the difference between a healthy pulmonary artery and how once the pH, see how the vascular changes have happened? So it's making itself, so it forces itself to have the high pressures.
Yeah.
That is no bueno. Okay, so once it happens, we have to, as I said, my religious experience, they can quickly spiral. I remember taking care of a kid. She was a kid who had a congenital heart defect, but she was coming in to have choanal atresia done, where she had the blockage in the nostrils. So the ENT doctor didn't bother to tell the anesthesiologist, and the anesthesiologist really didn't put together, because it wasn't a cardiac one, that her defect could give PAH. So during the choanal atresia surgery, she had a PAH spell and ended up on ECMO, which is long-term heart-lung machine. And I admitted her back from the OR. That's when I learned that when I'm stressed, I sweat. I could have wrung out, I had a washcloth, literally, and I was doing this all night. And yeah, it was another one of those. I don't normally drink, but that morning I was looking for something. Okay, so things that you need to know about with PAH, if you're into knowing about PAH. So things that will, and if you think about it, it's a lot of the things we talked about with TED spells. Okay, so we're decreasing the blood flow. The causes are hypoxia. Isn't this what we just said for a TED spell? Acidosis. Hyperinflation, just hyperventilated. And cold. Those are things that can make you have a PAH crisis. So if we want to fix it, and of course, get them mad. Anytime you get somebody mad, you run into issues. So what happens? The SATs drop, and they turn blue and bluer. And you just watch the SATs. It's just, they're starting out at 97, 98, and you just, remember I said, this kid went to 36. And they weren't a defect. They just had PAH. And I bagged her very slowly back up. And I think that finally my coworker showed up somewhere around 85. And I'm like, well, it's about freaking time. Okay, and once again, the spiral keeps getting worse, right? The acidosis makes you vasoconstrict. The hypoxia makes you vasoconstrict, so it just keeps getting worse and worse and worse. So what do we do for these people? We bag them, okay, with a lot of oxygen. We try and make them a little alkalotic. We're going to make them happy. Man, I was hitting the pumps and giving her boluses of Versed and fentanyl. I'm bagging here and I'm pumping here. It was bad. Okay? Avoid stimulation. That's what happened. I started it. She was on the ventilator and she was full of gunk and I had to suction her. And there were too many times that this happened to children. You're not allowed to suction cardiac kids alone anymore. It's across the board rule.
You have to have someone there with you.
2 people at all times.
You're just using like the bolster end?
Oh no, down the
deep
ET tube,
suction.
down the breathing tube,
Okay,
deep
okay.
suctioning. So what do we do with kids so we put signs above bed saying PAH precautions. And what that means is we're going to keep them happy. We're going to hyperoxygenate them for 100% before we do anything with them. So if I need to stick a kid, I'm going to throw some oxygen on them before I stick them. I'm not going to let them get cold. And I'm not going to let them get acidotic.
Okay.
Okay?
Can I ask a question?
Yes.
I like to think about why is it happening? So is this because of the increased blood flow? It's just the body's reaction to
Yes.
trying to decrease that so it doesn't overload the lungs with the blood
There's
flow?
different ways that it happens. Some of them were that they used to have the increased blood flow, then we fixed the procedure, we did the procedure, got rid of the increased blood flow, but the body is not acclimated to the increase, the normal blood flow again. So it's vasoconstricting because it thinks it needs to be high pressured. Or we have the kid that just did it by a fluke of nature where it just stays high. And those kids get worse when they get upset.
So how long does it take for the body to reacclimate to more of a normal
So
situation?
post-operatively, it takes about, amazingly, remember, these are kids, they're resilient.
Yeah.
24 to 48 hours for most of them.
Oh,
Yeah. So like the kids that we know are going to PAH bad, we keep them paralyzed and sedated on a ventilator, and we don't, and there's a huge sign on the door, minimal stim. Yeah, we just leave them alone and don't do anything to them for 24 hours. And then we slowly start to wake them up, and I do mean slowly. These are the kids that'll spend like a week in the ICU sometimes. If there's any worry, we'll put them back under.
But for those children that are a permanent condition.
Then we give them drugs that are going to help the PAH.
Okay.
There are meds out there. We start with things that work immediately, like we'll have them inhale nitric oxide, not nitrous, nitric oxide, NO. And that is a very potent pulmonary dilator. Then we can start them on meds, like we talked about, sildenafil, Viagra. And there's other meds out there besides that we can use. And then once we've got them on enough meds, then we can hopefully send them home. There's long-term IV meds we can send them home on, where they literally go home with a central line and a pump. There's some that are sub-Q, they can go home with an insulin pump. So there's all different avenues for the kids that are irreparable, that we can still give them time, and hopefully a lot of time, you know? Okay, I think I normally was going to wait on the break, but I think we need a break. Because I know, because the obstructive lesions, and then we still have the complex after this. So how about if we take like a 10-minute break, and then we'll come back? Okay, let's get started back. So there's two more sections that I want to talk about of defects, and then we can put them to bed. So the next one we're going to talk about are the obstructive lesions, where they're just not getting through for whatever reason. So pulmonary valve stenosis, anything that's got atresia or a stenosis in the words, and coarctation of the aorta. Coarc is an easy one, and it's one that I would consider thinking about. I kind of tried to make sure you got the difference between stenosis and atresia.
Oh my God.
Okay, so if you're atretic, it's the stuff, you really can't get in at all. Stenosis, you can try and squeeze through. Okay? But when you're atretic, it is closed, the end, you aren't going anywhere. So our best obstructive defect is our coarctation of the aorta. If you look up here on the aorta, you can see it's narrowed there. And it's also, because this is a newborn, what's still there? Does anybody remember what this one is?
PDA.
That's your PDA. So what really runs into place with these coarcs is, it's not too bad a deal as long as that PDA is open, because it kind of gives it a little extra room. But when the PDA closes, ooh, they start to have some problems. The coarctation is the one defect that you can diagnose yourself. Yes, you too could be a cardiologist. Okay, so if you think about where is the narrowing? The narrowing is after the vessels that feed the head and neck. Right, so everything from the nipple line up is going to get fed good blood flow. Everything's peachy keen. Everything below the nipple line, not so much. So if I'm taking blood pressures on a kid with a coarctation, what do you think is going to be different between the arm blood pressures and the leg blood pressures? Yes, significant difference, 10 to 20 millimeters of mercury. So one of the ways that we can diagnose this without an echo or anything else is do 4 extremity blood pressures. And you're going to notice the arms are definitely much better. Then you go and palpate radial pulses and pedal pulses. What do you think those are going to be like? 1 plus in the feet, bounding in the arms. Shazam, you too can diagnose this disease.
Where does the name come from? I always try to look at the roots of words, and I haven't been able to figure that one out.
I think, but in the land of Latin medical terminology, coarc means narrowing.
Okay. Thank you.
I'm guessing, but I'm pretty sure that's
It
right.
is.
It's not a doctor's name, so it means something in Latin. I've learned everything in medicine is one or the other. So if things can't get below that, can you see how failure to thrive, decreased perfusion, hypoxia could play into this? So again, we're either going to fix this in the OR or in the cath lab, doesn't really matter where. We're going to, for the coarc, we're just going to open it up. Now they have tried with these kids to go in just with a balloon. Yeah, well that doesn't last very long. So they actually go in and put a patch in place. But with the other atresia stenoses, they're going to go in and close holes and they're going to fix valves. But the worry we have, remember what I said about if blood flow isn't going there in the uterus here, no flow, no growth. So if they had a full atresia, whatever was below the atresia is most likely very small. So if it was a tricuspid atresia, okay, what's below the tricuspid valve? Your right ventricle. So you might have a itsy-bitsy like right ventricle. That would be no bueno. If it was a pulmonary atresia, once again, the blood couldn't get up into the lungs, right, through that method. So what is your pulmonary arteries going to look like? They're going to be real scrawny. There's no flow, no growth. So post-operative, again, noticing the continual trend of holes might be leaky, valves might be leaky, whatever we cut through could have electrical issues. Most likely, we're hoping if it's a corrective thing, that it wasn't because they have a small ventricle or a small something that wasn't repaired well, hopefully they will be normal after their surgery. Okay, so you just sat down, I'm going to make you do some more teaching. So I want you to think about all the different ones, right? The increased pulmonary blood flow, the decreased pulmonary blood flow, the obstructives, the atretics. What do they all have in common, and what do all the post-ops have in common? I'll give you a couple minutes to talk about it among your friends.
Take them off right before they walk out the door to make sure they're stable.
There you go.
Stable.
Okay, so let's keep going. So we're going to do the last of the lesions, and then we're on to the other stuff. So the complex ones, these are kind of like, I always, when you compare them, like if you compare cars, these are the Lamborghinis, you know, of the car world. So these are the big ones. These are the ones, you know, if they stood in the right line, they got their money's worth on their defect. So the ones that I will always think about are the truncus arteriosus. So truncus is where the arteries didn't separate like they were supposed to. So the truncus is the aorta and the pulmonary arteries are together. Okay, then we've got the transposition. I should have started with transposition. Again, we've got the arteries, instead of the aorta coming out of the left and the PA coming out of the right, it's the opposite. And if you think about preoperatively, you have two completely closed circuits. One side gets redder, one side gets bluer, and if you don't have a hole between the two, you're in a lot of trouble. What you're going to find is with these, the ones that don't have the hole between, what's kept them alive in utero is that PDA. Because there's full mixing at the PDA, right? And there's several defects that we're looking at here that have, as long as the PDA is around, they're in good shape. So they call them ductal dependent lesions. Because when the ductus closes, bum, 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 dead. It's just a little importance. So when we get these kids in and we diagnose them, we start doing things immediately to assure their PDA stays open. And what do we give them? What did I say we cut off when we cut the placenta? Prostaglandins. And what's wonderful is we have created prostaglandins, and we can put them on a drip. Woohoo! Keep it open. TAPVR, which I love those letters. Again, here we have the pulmonary veins decided to hang with all their cousins, the other veins. So instead of the pulmonary veins going back to the left atrium like they're supposed to, they bonded with other veins in the body. Sometimes we're lucky and they bond with the veins right up by the heart, so they're going back into the right atrium perhaps. Sometimes they bond with the ductus venosus. Remember me saying at the beginning, this can be a problem later? So imagine if all the red blood in your body is going to the liver. Okay? Because your liver really needs oxygenation, right? Not so much. So they really have a lot of problems with saturation. These are the kids that if they're not diagnosed in utero, they come out looking like roadkill. No matter how much oxygen you give them, no matter how much prostaglandins you give them, nothing works. Because all the red blood is going to the wrong place. If it's the bad kind where it's going down by the liver. If it's the other kind, then they have some CHF and they're okay. So TAPVR or PAPVR, partial, they can be normal or they can be roadkill. Anywhere, depending on where the veins are and how many are in the wrong places. And then this is the sacred cow. This is the one we still talk about the most, and that's the ones where you're born without the left ventricle, the hypoplastic left heart. Because last I checked, your left ventricle was just a little important. And even though we can palliate these people and fix them a little bit, that right ventricle was never meant to be a high pressure ventricle. And yet you don't have a choice. So our poster child for our complex is going to be our hypoplastic left. And these are kind of near and dear to my heart. When I first started at Children's, I couldn't believe how many hypoplasts we would get. And they all seem to come from El Paso. So, and we really still do get a large quantity from there. All I can think of is what is being thrown into the river. I don't know, but I just know we get a lot of them.
Is this happening because of mitral valve stenosis?
It's usually mitral valve stenosis. It's not usually aortic, it's usually mitral valve stenosis or atresia. So no flow, no grow. Everything below the left atrium doesn't work well. And if you kind of follow that with your eyes, so the blood comes back through the vena cava to the right atrium, to the right ventricle, goes out to the lungs, comes back to the left atrium, boop, it can't go anywhere. So guess what? That patent foraminal valley, remember the little door between the atriums that's supposed to snap shut at birth? Well, it ain't snapping shut because of the amount of pressures. So it stays open and things can move a little bit perhaps, but more importantly, the PDA. It's coming through the PDA. So when the PDA closes, they die. So if these kids aren't diagnosed in utero, and they look great when they come out because the PDA keeps them just fine. And I have never seen an ugly hypoplast. They're usually the most beautiful little kids, and they're almost always boys. And they're almost always white boys. So you'll hear PD nurses talk about white wimpy males because they just happen to be that. And they do fine, and then it used to be that these kids were diagnosed with SIDS because they'd be at home, their PDA would close, and they'd die in their sleep. So it's pretty much you feel kind of bad. There's a lot of them out there, though, and they're doing well now. They finally figured out how to but palliate them in the mid-'80s. So since the mid-'80s, hypoplasts are surviving and doing okay, and they're adulthood now. Okay. So, just like with the others, failure to thrive, hypoxia, decreased perfusion. Gee, here we got that reoccurring theme again for the preoperative ones. Again, we're going to close holes and fix valves, but a lot of these may be palliative rather than complete repairs, especially the hypoplast. Okay. And one thing they have found about hypoplast, the left ventricle on the left hypoplast, or if it's the right ventricle for the right hypoplast, because the ventricles are real small, they're very what they call pro-arrhythmic. They're very prone to PVCs and going into nastiness. And I really don't know why, but they just are. Maybe because they're small, kind of like Napoleon syndrome. Who knows? But they do have problems with arrhythmias, maybe. So let's go back to our case study. So case study number 1 talks about a hypoplast. Okay? So I think even though on this video it has the YouTube's first the Fontan, what I'd like to do is go back and do them in the right order. So when these kids are born with a left hypoplast, well, there's no ventricle stroke. So they did all kinds of surgeries back when they first started doing them to try and work with them, but they found that they can't just repair them at birth. The body doesn't tolerate all the pressure changes, So that's why they do them in 3 steps. So, and you'll never guess who the surgeons were who created these. It would be Dr. Norwood, Dr. Glenn, and Dr. Fontaine. And those are the 3 procedures that are done. So these YouTube clips are coming from, I think these are from CHOP again, Children's Hospital of Philadelphia.
Ventricle. That ventricle has the one good pumping chamber, which in hypoplastic left heart syndrome is the right ventricle. That ventricle has to pump to the body. So you have to connect the arteries to the lungs and the body in such a way that all the blood goes out to the body without any obstruction.
In HLHS, the aorta is usually too small. So we correct that by putting a patch on to enlarge it.
And that's done by connecting the pulmonary artery, which comes from the right ventricle, to the aorta, and then usually putting a patch on to finish the connection of those 2 blood vessels and enlarge the aorta.
In addition, you have to prevent blood from backing up inside the left side of the heart. So you have to cut out the partition between the 2 upper chambers of the heart. And then the third principle of the Norwood operation, or the first stage operation, is to provide some restricted blood flow to the lungs.
What we call pulmonary blood flow. And we do that by placing a shunt, a small tube, from one of the systemic arteries, or arteries that goes from the heart to the body, to the pulmonary artery.
That is enough flow that you can get enough oxygen in
Making
the
a
bloodstream,
permanent
but
PDA.
not so much flow that you have resistance problems.
Now, each one of these 3 has a 50%
The second stage operation,
I'm sorry?
Each one of these 3 surgeries has like a 50% chance of death.
Not anymore.
Okay.
When they first came out, yeah, it was even higher. When you talk with Norwood, now remember when they start quoting mortality rates, they're talking about making it out of the OR and making it home. They're not talking about making it to the next surgery. The numbers are in the double digits, but the low double digits. 10, 12, 15% for the Norwood. The Glenn, it's even lower. The Fontaine, it's even lower. The problem is, between the first surgery and the second surgery, you have full mixing of blood, right? The aorta and the pulmonary artery are one thing, and everything is mixing. So what's your set on a kid? So think, okay, let's do math, easy math. I promise easy math, not hard. Because it's 7:30 at night, we're not going to do hard. Normal set on a human is?
95.
Let's say 100 because it's easy math.
Okay.
Normal venous set on an adult, on a normal person? 75, 80. So if I take, let's take 70 because it's easy. 70 and 100, 170 divided by 2, 85. The best set this kid's going to have between his first surgery and second is 85. So when these kids go home with sets of 78 and 80, we're like, okay, because they have full mixing. So it takes 100% of their cardiac function to just live between those first 2 surgeries. So snotty nephew comes over to visit. I just told you it takes 100% for them to live healthy. What's going to happen when they get a cold? You see why I'm telling the parents, you screen them at the door, you don't go to Walmart, you don't go anywhere until at least the second surgery, which is somewhere between 4 and 6 months of age. So that's why they're isolated. You know, I usually tell them, if you want to go to somebody's house for Christmas, go there, don't make them come to you, because a lot of times people are ignorant and they're going to bring their sick kid with them anyways. Or you can go there, you see someone walk in the door that's sick, you can leave. So that's usually the way, you know, I put the fear of God into the parents. I said, you have hand sanitizer at every table throughout the entire house. And nobody touches your kid without doing it. Gel in, gel out, every time you touch the kid. It's not gel in and gel out of the house. It's gel in and gel out of the kid. Because you don't want them to touch anybody. You know, I mean, that's how you have to be with these Norwoods. So the chances of them dying before the next surgery, that goes up quite a bit. You know, there's a good chance up to 25, 35, percent can die within that 4 to 6 months. Once they get to the second surgery, they get much hardier, and they usually do fine. But you're not going to hear anybody quoting how well they're going to do living until the next surgery, because they don't want those numbers out. Okay. Okay, so this is the set. So, by the way, that shunt that they were talking about, remember I said it was a permanent PDA? That shunt is called a BT shunt after Doctors Blalek and Taussig. The something God made, people. So that's the shunt that we use for TETs before we had heart-lung machines. So we're still using that BT shunt, we're just using it for other people now. Who knew? Okay, so let's go back. So this is the second surgery when they come back in at 4 to 6 months of age.
The second stage operation takes away that extra volume that the heart has to pump. And it does that by getting rid of the shunt and connecting the veins from the upper part of the body directly to the arteries to the lungs.
You have to wait until the lungs essentially mature enough that you can provide a different source of pulmonary blood flow.
This is
We
called
didn't know
either a
that at first. That's why they all
bidirectional
died.
shunt or a Hemi-Fontan operation.
So that's the 4 to 6 month one. This last one is the Fontan, which is done somewhere around the age of 4 years. This is going to finish off separating the blue and the red blood.
Normally, the inferior vena cava, which drains the bottom of the body, attaches to the heart at the inferior bottom portion. And what we do is to literally divide this from the heart. We sew up the portion of the heart where the inferior vena cava entered, and then we sew a tube end to end to the remnant of the inferior vena cava. We take this tube and loop it around the side of the heart and sew it into a hole we make into the pulmonary artery. So we essentially bypass the entire heart.
It's a more efficient connection because the tube is a very specific size and the blood going through there is not turbulent. Turbulence loses power. Power loss is a problem if you don't have anything pushing blood through the lungs.
Now the one modification is that we put a small hole in the side of the heart and in the side of this graft and sew it together with what's called a fenestration.
And the reason we do that is that it's been shown that having that little hole, while it does allow some blue blood to mix with the red blood, it also decreases the risk of developing fluid around the lungs after surgery. It's something called a pleural effusion.
It's a pump-off valve. I mean, who would have thought to do stuff like this? So you got to give these surgeons credit.
I watched the podcast.
I'm sorry?
There was another video right after that from Khan Academy.
Yes.
Put all three in together. I watched that one.
Yeah, Con stuff is good, but on the other hand, Con stuff is also a little long-winded. That's why I didn't use any of them for today. What's the other one? Khan Academy I like, and then there's MedCram. They also do some, especially there's shock lecture. I like MedCram. 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 Okay, so let's go on to Harrison Sullivan. So he's coming into the hospital, he's 3 years old, for a preoperative workup for his Fontan. And we now know what a Fontan is. So that's when we're going to have all the blue blood go directly to the pulmonary arteries. So the inside of the heart can only be red blood. Okay? So that means it's passive, right? There's no way that, so do you think we would ever want to, if a kid blood pressure dropped, put them in Trendelenburg where their feet are up and their head is down? Do we want this kid to get constipated so he has to bear down to poop? Okay? So those are kind of things you want to think about with kids that have these kind of surgeries. So today, here's his vital signs: 36.6, heart rate of 126, respirations of 36, BP and SATs. And he has a murmur. Anything about those make you nervous?
I thought his pulse and respirations were a little high, but he's also still got some mixing of blood. So he's going to be working harder.
Right.
Just to oxygenate his body.
Right, so his heart rate and respiratory rate, although abnormal for a normal 3-year-old, for a not fully palliated heart, aren't bad. And the same thing with his SAT. I would hope, as a Glenn, his SATs would have been in the mid-to-upper 80s. But not so much today, not with this kid. So what about this murmur thing? Is murmurs a good thing? For him it is. Okay, when kids have shunts, like when the Nor would have that BT shunt, or he's got that big tube that's connecting things together, right? Things are still mixing. Murmurs are good things. So like when I have a post-op Norwood, when they're 2 weeks old and they're still in there recuperating, and their shunt goes away, that's instant OR. Because that's telling me his shunt has clotted. His murmur's gone, his shunt is clotted.
Is that the one that sounds like a mechanical?
It's a whooshy sound. Whoosh, 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 whoosh. Instead of love, it's a whoosh. They do sound like a little bit like washing machines. Okay? So in your own words, can you, after watching the video clip and hearing what I was saying, do you think you could tell me? You don't have to say it out loud, but could you tell me what a Norwood is? What a Glen and a Fontaine? Or at least you have a vague understanding. That's all you need at this point in time.
It's vague.
It's vague. Okay, what's happened is we've separated out all the blue bloods on the outside and all the red bloods on the inside. But we're still expecting that right ventricle to do all the pumping. What I'm expecting, this is my own Michelle Trenka thoughts, I'm expecting these kids in their mid to late 20s to start showing up needing heart transplants because their right ventricles are going to start to fail. Because they're not meant to hold high pressures.
And they're basically pumping the blood throughout everything. It's basically like one pump.
Right, it's one pump. They only get one. So they're doing double work. And it's the morphology of the right ventricle. If you think back to your pathophys class, the morphology of the ventricles at the cellular level is different. That side is not meant to be, a blood pressure of 120/80.
Yeah.
So I'm expecting to see these people sooner or later show back up again. Okay, so knowing what you know about them, so we already talked about the vitals, so we don't have to do that one. Today he's scheduled for an echo. What's an echocardiogram?
Sonogram of the heart.
It's a sonogram of the heart. So any kind of special, what would we tell the parents? Do you think everybody knows what a sonogram is these days? Okay. So is it going to hurt?
No.
No? I think the hardest thing as a nurse is to stay awake. Because you're in the room and it's usually warm and quiet and dark. You do that to a night nurse, they fall asleep. Okay?
Maybe the kids' sedatives? Is that
Yes.
normal?
Do you think you're going to get a 3-year-old lay still for
My
you?
son has a heart thing, and they've never given him a
They've never given him a sedative? Wow. That's impressive. Huh. Impressive. We have a tendency to give heavy drugs. Not tons of them, just enough so that they mellow out and they're not squirmy-wormy. If we've got a cooperative kid, we won't, but most of these kids don't want to lay there very long. Okay, so how would you prepare Harrison for his surgeries, knowing what a 3-year-old knows? So am I going to tell him that we're going to separate his inferior vena cava and put it directly to his pulmonary artery? Okay, what am I going to tell him?
Make your heart
Try to
work
fix your
better.
heart.
That's good. Try and fix his heart. Is it going to hurt? Never lie. It's going to hurt, but we're going to give you pain medicine so you'll be okay. Mommy will be with you until you go to sleep, and Mommy will be there when you wake up. Those are your daddy or whoever it is, significant parent type person. Okay? So let's fast forward. Now Harrison is scheduled to be discharged to home. What kind of things do you think we're going to have to teach the parents? So the basic stuff that we talked about, right? Infection, bleeding. I'm hoping not bleeding anymore, but infection's definitely a biggie. Pain. Might still have. His meds, right? These kids aren't going home med-free. And if he's not very big,
Failure to thrive.
Failure to thrive. So he may have to go home with a feeding tube in still. So we can feed him overnight. He eats during the day, and then we feed him overnight. Like CF kids, right? Isn't that what we do with CF kids? They eat normal all day, and then overnight they're on continual feeds. What other kind of things do you think we have to teach them?
Alcohol all over the place. Like you said, the long hand. Since
We're completely separated out now. They're pretty hardy kids.
okay.
So they still should be screened, but not as much as they were before. It's
Warning,
between the Norwood and Glen that they have to be really
warning signs if they start to go downhill.
right. So we need to talk about signs and symptoms of when to call the doctor, signs and symptoms of when to call 911. Make sure they know what the meds are, how to draw them up, how to administer them, which ones they're going to hold if the kid gets sick, which ones if the kid throws up would we re-administer, which ones wouldn't we? We cracked open the sternum, right? And yes, we wired it back together, but we still, is that bone healed yet? How do we pick up a 3-year-old? Am I going to be able to pick a 3-year-old up under the arms if I've cracked that sternum just, a week and a half ago? No. So you're going to have to make sure that they know not to lift them like that, to lift them this way, right? Lift them so they're lifting under the knees and behind the back. So those are the kind of things. Now, trying to think. Also need to make sure they know what they tell the pediatrician, what they tell the pediatric cardiologist. Because the cardiologist is not going to do well baby checkups. So they're double following, right? So you need to make sure they know. So you're not going to call the pediatrician with cardiac issues, but you're probably not going to call the cardiologist with pediatric, just regular pedi stuff. Make sure that they understand that this kid cannot get dehydrated, right? So a lot of adults don't realize how easy a kid can get dehydrated. Alrighty.
Would they need
Okay.
to wear like an alert bracelet for life?
They probably should. I know that we've got, in the weekday senior one group, we have a right hypoplast. Because she came and introduced herself and told me about her history. And when she said that, I was thinking, well, I used to think that you had lipstick on, but maybe not. Because her lips are a little on the bluer side. She said her SATs at about 88, 89. So, but I thought it was pretty cool that she would come and tell me about it. Okay, so Harrison's on DIG, Lasix, lansoprazole, aspirin, and enalapril. What are these meds for?
One's a antifungal, strengthening the
Okay, DIG is going to increase squeeze, slow down the heart, right? Everybody knows furosemide, right? Vitamin L, Lasix, right? What's lansoprazole?
antifungal.
Right?
It has a PPI. It's
Oh, the
a
proton
proton pump inhibitor.
Yeah, they're proton.
GERD seems to be a real common problem with these kids. Why is he on aspirin? No, not pain.
No, the blood
Blood thinner, right. We don't want the PA, right, the vena cavas that are directed to the pulmonary artery. We don't want those to clot. So he's probably going to be on aspirin for a good long while. Enalapril, what's enalapril? It's an ACE inhibitor. Are they hypertensive?
No, but you're gonna vaso control.
They unload, right? They help get rid of afterload. So it's going to decrease the work on the heart. So that's why. So do you think the enalapril is going to be there? We're going to tell the parents hold it for a low blood pressure, not unless it's super low, and they're not taking blood pressure, so they'll never know. What about the DIG? Are we going to tell them anything about DIG?
Yes, potassium toxicity.
Right, but they're not checking potassiums at home. But what are they checking at home? They can't check their pulse, right? So on an infant, we don't like pulses to get under 90 for DIG. Might want to know that. Grown-ups, we say we hold DIG if their heart rate's under 60. With kids, it's under 90. So mom asks you if Harrison will still have problems where he's turning blue. What would you say to mom?
Will they have an oxygen taken home that they can
No.
use?
No. They're
Where
gonna
are
go
their-
home. Where they are is where they are for life.
What are their other presenting symptoms? Like, do they have a fever, or like, do they have other symptoms that could worry that they might have a bigger problem? Because there might be. Well, no, you said that they're already better.
Well, if it's after
We've
the
completely
Fontaine-
repaired them.
if it's after the Fontaine.
Right.
wouldn't they
After
have
the
normal
Fontaine,
sat?
you're going to tell the parents they shouldn't be turning blue, and if they are, you need to call people. You need to see the cardiologist because we fixed them now.
Does that mean there's a failure in the?
There might be a failure, but then again, maybe the kids. Although think about it, if the kid is constipated and bears down, he's going to cut off his cardiac output. He's just going to pass out.
Should
He's
that
not going to turn blue.
should that kid also be on like a stool softener or something like that then?
Only if they need it.
Okay.
Yeah, they're going to try and avoid as much as they can.
Okay.
But if they need it, they'll do it.
When I was reading about this, I got to thinking about their body is so used to the lower oxygen saturations. Once they are repaired and they have the higher oxygen saturations, how long does it take their body to respond? Because I was thinking of, when we learned about like COPD, if you increase their oxygen, their sats will actually drop because their body's used to the lower sats.
These are kids. They will bounce and acclimate very nicely. So, but you're right. When you're in utero, remember I said baby's arterial is mom's venous. So the best sats you're going to see in utero are going to be in the 60 to 70% range. On a good day, that's what their sats are. So when they're born and their SATs are 60, nobody gets upset because that's what they've been living at for the last 9 months. It's us, when our SATs drop under 90, we get loop-de-loop because we're not used to being hypoxic. And we'll get confused and combative, but these kids don't because they've never been good. You know, it's like anything else. If you never have it, you don't miss it.
Yeah.
Their bodies never had good SATs, so they tolerate it very well. And they're slowly going up, so they just acclimate to the higher SATs and do fine.
Is pervasive delay really common with these kids to go along with that developmental delay, to go along with the failure to thrive and those other issues and not getting oxygenation?
Not as much as it used. We used to see it more because of the surgeries. When you put somebody on a heart-lung machine 3 different times, we didn't really know what kind of good brain perfusion we were getting. But now that we have near-infrared spectroscopy, where they put, the little red light that's on the finger, you can put it on the brain, you can put it on the kidney, and get your venous SATs of your brain and your kidneys. Now that we know that those SATs don't drop like they used to, we're not finding as much learning delays and stuff that we saw in the 80s and 90s. Now they're pretty much peachy keen. So that's something that's, now if they had problems post-op with low cardiac output problems, that's a whole other problem. But for kids who do well, no. Okay. So, teaching necessary to assist the parents provide safe postoperative care for the first few days after surgery. So we kind of talked about one of the things, right? The sternal thing, we don't want them lifting them. Do you think they're going to be able to throw them in the bathtub in the first few days after surgery? Do you think they're going to have some chest tubes in for drainage? Not pleural, mediastinal. So these are tubes that are sitting here that are draining the pericardial sac. They could have a pleural in because they could also get some pleural effusion. Remember they said? Yeah. They do that fenestrated Fontan to decrease the amount. Remember I said fluid's lazy. If it's not used to having all that fluid go to the lungs, it's going to say, forget this, I'm going to become a pleural effusion. I'm going to become a peritoneal, peritoneal effusion. So you might see fluid other places, so you need tubes. Now, just for argument's sake, if we've got somebody with chest tubes in a postoperative period, we should be seeing decrease amounts, right? Mm-hmm. And we should see them changing colors. Maybe in post-op they're bloody. By post-op day 2, if we still have them in, what color is it?
Serous.
By then it'd almost be serous, yeah. Serous sanguineous in the middle where it's fruit punchy, right? Mm-hmm. But then we go to serous. So when we think about adults in chest tube drainage, we don't get really upset until they're really putting out a lot, right? 100 or 200 an hour. With kids, just like everything else, we do it in mLs per kilo per hour. And anytime we see more than like 3 mLs per kilo per hour, which doesn't sound like a lot, so let's say I have a 3-kilo kid, and they're doing 3 mLs per kilo per hour, that's only 9. But when you add it up to 27 in 3 hours, that's a lot of blood for a little kid. That's a fluid bolus. That's a lot. It'll make a big difference. So when we start seeing numbers of, 3, 5, 7 mLs per kilo, they're bleeding. So in the post-op period, and they can bleed a couple days post-op still. They could be fine and then all of a sudden start bleeding because a suture came undone, something like that. Okay. I think we did all that. Good. Let's keep going. So I think these were things that I've already said. Fluids are lazy. We'll always go the path of least resistance. No flow, no growth. You want to feed and grow them so they get bigger for their next surgery. And you'll see that over and over if you ever work on a cardiac floor. We talked a little bit about ductal dependent lesions. Keep them open or they die. And that's that. Do we need another break? Okay. I mentioned it. It took me a while to get to one, but so you already know about CAN. So MedCram is another one. MedCram is actually done for med students. So they're a lot more pathophys, but I still like them. But they're also a little long-winded. Okay, next thing we're going to talk about is shock. Don't ask me why shock got associated with the cardiac lecture, but it is. So I'm here to talk about it. And if you look at the slide, this bolded area is a little important. The fact that it's saying 100% of the time, if you don't intervene in shock, they will die. Not necessarily on your test, that's for real life. You don't reverse shock, they go to God. The end. There's 4 types of shock: hypovolemic, septic, obstructive, and cardiogenic. When you have somebody in septic shock, you'll hear them talk about a petechial rash. It's a very scary thing when you see. You call everybody and their brother. The reason that glass is there, because what they're showing you is, if you press down on a petechial rash, it doesn't go away. Like if you get a rash from an allergy and you press down, it goes away. And then let it go back up, and then it comes back. Petechial rash is blood hemorrhaging. It isn't going to go away. And petechial rashes, if they get worse, will go to purpura. Then you really get scared. Modeling is telling me that they're getting poor perfused. And when you see that, again, it's another thing that you want to get scared about. So in kids, remember I've been saying all along, very resilient. Their body has pristine organs. They haven't been going to Mickey D's for 20 years. They haven't been wearing out the couches in the land of couch potatohood. So they can compensate very well. I know I do a lecture where I say that pediatric nurses have to be detectives, because they will compensate until they crash. There is no going downhill in peds. They compensate, they fall off the cliff. That's how it goes. So if you're not good at detecting work and picking up that they're compensating, you're going to miss it. And like I always like to say, you're going to miss the boat, the cruise, and the whole vacation. If you're waiting for a kid's blood pressure to drop, you will miss the boat, the cruise, and the whole vacation. They can maintain a blood pressure when 25% of the blood in the body is gone, or they're dehydrated at 25%. That's a huge amount. Nowhere near, we would be, completely out, blood pressure of 12 with that amount. But kids can tolerate it that well. So that's why we've got to figure out when they're compensating and get in the way. So the way I like to think about shock, because I'm very photo in my mind, I have to be able to picture things. So when you've got shock, if you go back to that last slide about words, where it says, definition, inadequate delivery of oxygen to the tissue, supply and demand. Whether it's due to a pump, whether it's due to vasodilatation, it doesn't really matter. For some reason, the body is not getting perfused. So when we go through this, for the long time, the body will compensate. So the body tells itself, hey, I'm not getting perfusion to my extremities. And the heart comes to the rescue and says, I will save the day. And the heart says, I am going to increase cardiac output. Now, can an immature myocardium increase squeeze? No. We all remember the formula for cardiac output? It's stroke volume times heart rate. So if I can't increase stroke volume, what's a kid going to do? Heart rate. So all of a sudden the kid is tachycardic. I have to figure out why they're tachycardic. And there's easy things that can make them tachycardic, right? Load in their diaper, they're mad at me, they're in pain, they have a fever, or they're going into shock. So I have to make sure that if I'm tachycardic, that they're tachycardic for a benign reason, not because they're getting shocking. So the tachycardia is working, and the heart's done its job, and everybody's getting perfused, and everybody's happy. But remember that slide that said what happens 100% of the time if you don't intervene? They die. So they're going to get worse. So after a while, the heart says, I can't work any harder. Find plan B, because I'm done. Call it a day. So the body is very smart, and it goes, triage. Who can we cut off and still live? And what can they cut off? Extremities. So that's when we start to see poor perfusion to the extremities. Hands and feet are cold, that modeling can occur. You feel the pulses, and kid pulses are always 2 to 3 plus. All of a sudden, they're 1 plus with an imagination. Nice and threatening. Okay? I've had a lot of 1 pluses with imaginations over the years. How do I check cap refill on a child? No nail beds. I've had a kid with brisk nail beds who was on code dose epi drip. When my preceptor turned the hand over and did this, My cap refill was 5 seconds. So you want to do either the hands, the top of the hands, the heels of the feet, no nail beds in kids.
Huh. And that's to what age? Like,
Until you get to teens.
wow.
You can even do it on adults. You don't have to do nail beds.
Yeah.
You can do it there.
Yeah.
It'll work on the pads of the fingers. If you're cold right now, as I know some of you might be in this room, you might have a little bit of a delayed cap refill. Okay, so I have literally seen kids with a cap refill of 5 seconds, tachycardic, unresponsive, like I can stick them with a needle and they don't move. You know, I'm drawing blood or whatever. And guess where their blood pressure is? Normal. It's creepy. Okay, that's why on this slide we got the blue versus the purple. The blue is we're compensating, we're compensating, we're compensated, we crash. Purple's black, that is the crash. So we've got to catch them while they're still compensating. And they're going to compensate for everybody. No matter what kind of shock, they will compensate for the longest time. But when they crash, you better be ready to start CPR because it's going to be around the corner. Okay? And it's kind of basic. What do? We do their ABCs. This is exactly what you're going to look for ACLS. You assess their ABCs, you call the right team. If they're still alive, it's probably rapid response. If they're dead, not so much. Give them oxygen, breathe for them if their A's and B's aren't working good. Put them on monitors. For shock, we want to establish vascular access. Give them fluids, and if fluids aren't good enough, give them pressors. That's one of the big differences between adults and peds. In the land of shock, everybody gets fluid. Because you're not going to know they're in cardiogenic shock until you give them fluid and make them worse. So I put this handy-dandy little table together. So this is just out of my brain from teaching PALS and ACLS for too many years. So if you notice across the top, it's telling you what's causing the different types of shock. Look at my symptoms and look at my treatment. Doesn't matter what kind of shock, we're doing the same things. Then, what was our response? If I'm hypovolemic, I got the pukes and the poops, I'm going to respond and I'm going to get better. And I'm going to just keep getting better and I'm going to keep giving more fluid until they're 100% perfect. If they're infected, they're septic, or they're in distributive shock, I can still give lots and lots and lots of fluid. And only if the fluid can't keep up with the blood pressure, then I'm going to go to my pressors. Otherwise, I can keep giving fluid. And we give a lot of fluid. We give 20 per kilo over and over and over again. You can give these kids like 60 per kilo. Just boom, 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 boom. So think about it. 60 per kilo, if you're talking in people terms, okay, I'm a big lady. So I weigh about 100 kilos. So we're talking about giving me 6 liters of fluid. I don't think I'm going to tolerate that, but they do. Because remember, they have pristine organs. They can tolerate it. Yes?
What's the mechanism of that? What is the fluid doing?
The fluid is filling up their vascular space. Because for whatever reason, they're either dehydrated with hypovolemic, septic distributed, that means they're vasodilated. Their SVR is really, really low.
So you want to fill it.
So we want to fill it up. That's why I said we're going to try and give them some boluses, but if you're not making headway, you're going to go to a pressor. But you're going to always start with fluid. With the cardiogenic, when you gave the fluid, they got worse. They now have a gallop. They now have their lungs are wet. They can't handle it. We just made them worse. But because they come presenting the same way as everybody else, you're almost going to have to make them worse to figure out what it is. Then you call the right people and they get better. Obstructive shock is when there's a physical cause for the perfusion to go down. Cardiac tamponade, collapsed lung, tension pneumo, crushing injuries. So if you give them fluid, it may or may not help. Most likely it won't. They're not going to get better until you fix the problem. So,
So you said the cardiac tamponade, crushing, and then you said
tension pneumo.
Tension pneumo, and what else?
Trauma.
Okay.
It's all up there. Physical cause, tension pneumo, tamponade, trauma, injuries. Okay. I tried to put it all on one slide.
So I'm sorry, I'm just trying to, maybe my brain isn't working at this second. I don't know.
And
if it's
that's
time of the
understandable
night.
after all these hours.
So you said you would do the 3 boluses, and if that doesn't work, you give vasopressors?
Well, you mean for sepsis?
Yes, for sepsis.
Right. Usually, yeah, because what's going to happen is you give the first fluid bolus, and you might see a smidge of improvement. So in the meantime, I'm also, somewhere on here I think I said, you're going to have to talk to the parents and find out what's going on.
Yeah.
What, so if mom tells you they're coming in with the pukes and the poops,
You already know.
you already know
Yeah.
where you're at.
Yeah.
Mom comes in and tells you everybody in the house has been sick. You've got a clue that it might be sepsis. They might already have some mottling and petechial rash going on. Mom tells you that a month ago or 2 weeks ago they had a viral infection that went away but they never bounced back. That's going to be your myocarditis. We'll cover that again in a minute. Don't worry, I got a table for that one too. One of their lungs doesn't go up and down. You can't hear their heart sounds. I'm sure for adult too, you've got to learn the symptoms of tamponade and tension pneumo. If you haven't yet, you will. They're not going to let you out without knowing those. Okay, but I tried to put it so you can kind of compare and contrast. But the difference between shock management in kids and in adults is in kids, everybody gets fluid. Now, what kind of fluid am I going to give, do you think? Isotonic. Either lactated ringers, or more importantly, that they usually give, normal saline. 0.9 normal saline. They can give other stuff, but 0.9 normal saline, when in doubt, give it. Okay? Alrighty. And we already kind of talked about this on the slide before that, so I'm not going to go into it too much at this point. So we're looking at all of them. Remember I said blood pressure, last thing to go. So what are we looking at? We're looking at their perfusion, we're looking at their vitals, we're looking at their level of consciousness to figure out what's going on. I can't tell you enough how important listening to parents are. Parents know their kid, unless they're newborns. Then you take your own one. But if they're not a newborn, because the kid may look perfectly fine to you, but mom knows this kid has ADHD and he doesn't sit down until he falls asleep. So a kid watching TV very nicely that we think is fine is sicker than snot. So you always, always listen to the parents and peds. Unless they're psycho. I had one lady who used to go out and talk to the squirrels. She was just, okay. Something that we use a lot of in kids and we're starting to use more and more in adults. Remember I said we've got to get fluid in them. Well, if they're so dehydrated that you can't find a vein, what do? You go to the bone, right? What can I give into the bone? I can give anything to the bone that I give to the vein. I can give fluid, I can give blood, I can give meds. So it's a great thing. Okay? EasyIO is one of the types of drills that we can use, so you don't have to just with your hand. Okay? And it really works nice. You just put it in, and you're in. Yes.
And
I know it's kind of gross, but it works.
Anybody can do that?
You have to be credentialed. I mean, but it's an RN thing. Yes.
No, I know. I'm just saying.
She's like, I want to do it tomorrow.
No.
Yeah.
I don't know if only the physician could do it, or
No, it's not a physician. Because I still remember going to a code, and the ICU fellow looked at me and he handed me the IO, and I said, "What do you think I'm going to do with that?" And he said, "You're going to put it in." I said, "No, you can put it in. I'll get the tubing ready." And it wasn't that I legally can't do it. It's just I've never done it, and I didn't think that was a good time to start.
Yeah.
So he put it in. I got the tubing ready to go, and we lived happily ever after. Keep in mind, if you're putting an IO in, it's going into a closed space. Is the IV tubing going to go drip, 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 drip? No. You're going to push it or put it on a pump. It's the only way it's going to go in. And remember, pain is the fifth vital sign. It would hurt if they were awake. By the time they're awake enough to realize this is uncomfortable, their veins have popped back up when we get an IV in and pull this out. IOs are never in for more than like 8 to 12 hours. Because by then they're either dead or we've got them healthy enough to put other things in. Okay, enough about shock. You want a break before we go on to acquired? No? Yeah? Little break? Okay. Just a little break. Potty break, real quick. Excuse me, what do we say? Comfort break. Alrighty, so now we're going to talk about the acquired. So these are the things that you get later on in life. You ain't born with them, right? So PAH can be acquired later on. But I'm not going to talk about it again. Thank goodness, right? Myocarditis, endocarditis. We'll get into that. Cardiomyopathy, Kawasaki, and rheumatic fever, rheumatic heart disease. So, endocarditis. Endocarditis is why all the congenital heart kids have to be put on antibiotics anytime they have dental procedures done or any other kind of medical procedures where they're going to move around and redistribute their bacteria. Because remember, every time you brush your teeth, you do a flush of bacteria into your bloodstream. Yes, that plaque, it's got cooties in it. So if we're going to be doing dental work, think about how much more invasive that is. So we are going to give anybody who's got bad hearts, bad valves, bad hearts, they will all be on prophylactic antibiotics so they don't get endocarditis.
I thought they had stopped that practice with adults at least.
Maybe in the adult, not for mitral valve prolapse?
My wife has one and they don't
do it anymore? Okay. I'm a little dated because I don't do adults that much. But with the kids, they still do it.
Okay.
What's that?
Prophylactic antibiotic before dental work.
No, yeah, I did dental in the military, and we still do it, but we're behind, so I don't know.
My kind of place. Okay, myocarditis happens to normal hearts. Endo happens to jacked up hearts. Myo happens to normal hearts. Endo is the endothelium, the inside of the heart. Myocarditis is the muscle of the heart. So this is the kids, they'll come in saying they had a viral infection 2 or 3 weeks ago, and they just never bounced back. So they come in, they haven't been eating or drinking much, so they come in looking an awful lot like hypovolemic shock, till we give them the volume, and then they go into CHF. And that's how they get diagnosed. What's kind of sad is this 1/3, 1/3, 1/3, and this works for adults with myocarditis too. 1/3 of them will be sick for a little bit, and they will get completely normal again, like it never happened. 1/3 of them are going to get really sick, and they're going to have some problems for the rest of their life. The final 1/3 are super sick and perhaps die. If they don't die, they're going to end up on ventricular assist devices, probably need a new heart. So you want to always hope that you're the first 1/3, not the last 1/3. Okay? So I kind of put it together on a table for you again, so that you could compare and contrast. So the big difference between them is where it's at, and from the words endo versus myo, you can figure it out. Endo is something that happens to people who have, a lot of turbulence inside the heart because they have a bad valve, stuff like that. They have a catheter, like a central line catheter sitting in there that can create it. So there's usually something, a thing that, now the one time that I would say, there's always an exception to every rule. I remember taking care of a 30-some-year-old guy who was an IV drug abuser. He ended up with endocarditis and nasty valves with fungal infections on them from using bad needles. So he didn't start out with a bad heart, but he ended up with one. We were able to resolve the fungal infection on the valve. We told him, if you go back to shooting up, it's going to come back, and that'll be that. And 6 months later, he came back as a stroke. Remember I told you, 30s. And another bad fungal infection on his valve, and the surgeons refused to do a valve replacement. They said, we told you what would happen, you did it anyways. So here we have a 30-some-year-old gentleman who's now a stroke patient, and he was a bad stroke, who has, end-stage cardiac disease. Because, man, addiction can get you.
Did the fungal infection come back because he was using? Or
Oh, yeah, he was using. Yeah, he had the track marks, it was all there. Yeah. And I still remember his girlfriend was threatening to sue. And the surgeon and the cardiologist just looked at them and said, we documented this so well in his chart from last time, you go right ahead. They didn't. Okay, so endocarditis is usually bacterial, so that's the one that's going to need weeks of antibiotics. Myocarditis is almost never bacterial. So this is one, the damage is already done from a virus. There's not much we're going to do other than support the heart. Are they pretty clear? Okay, good. Cardiomyopathy can happen from lots of reasons. It can happen from the things we just talked about, or it can happen from a bajillion other things. There are 3 different kinds. Big heart, right, dilated. Thick heart, hypertrophied, or stiff heart. They are all types of cardiomyopathy, bad heart, bad functioning heart. The one we usually think about the most is the dilated, right? Where you have cardiomegaly, where you do a chest x-ray and instead of the heart being the size of your fist, the heart's about this big. I remember the one time I made it to the OR to see a heart transplant. They took the dilated cardiomyopathy out and put in the nice normal size. And you know, because we're so used to more is better, there was a part of my brain that's going, is that going to work? But of course, the small one was better, but you know, it was just very weird. So again, we're going to monitor the person, treat their symptoms, and depending on how bad it is, we're going to have to go to more aggressive things. And I think that's enough just so you understand that it exists. Now we'll go on to congestive heart failure, because we've talked about it 6 different ways already. So I'm going to kind of go through this a little on the fast side. Bottom line, the supply and demand is there. Everybody remember what movie this was?
Oh,
Bill and Ted?
Bill and Ted.
Yeah.
Excellent.
Yes. Just love those guys. Okay. So, oh, look, it's a blue star. Okay, condition in which the heart cannot pump enough adequate oxygenated blood to meet the body's demands. Same difference. Okay. So, lots of stuff. I don't think I would memorize this. There's just too much there. There's no blue star on the page. But you got a bad heart. Somewhere along the way, you don't have good enough pumping, so things are going. Now, in adults, you'll see a lot more of the right-sided failure versus left-sided failure. In kids, you pretty much see CHF, period. They don't seem to isolate from one side to the other when they do it. So I'm seeing funny looks.
No, right, they're more left-sided. Adults have more left-sided issues than right. You said right-sided.
Well, what I'm saying is it doesn't matter if it's right or left. When kids go into CHF, they're going to fail both sides. They don't, where adults, they'll fail most, one side or the other. You'll see symptoms from one side. You can, in other words, when you look at an adult with CHF, you can say, oh, this is right-sided failure. Oh, this is left. With kids, they just look like roadkill. It's just pretty much the whole heart. You're not going to really be able to differentiate one side from the other. They just plain old fail. Okay, and as I said before, they're going to have the same symptoms as the adults. So they're going to have the gallop, they're going to be tachycardic, they're going to have the wet lungs. When you look on their x-ray.
How do you know if it's shock or CHF if they're both because of, like, there's not enough oxygen going to
Okay, so the difference between CHF and shock, sometimes it's a little hard to tell, but in CHF and cardiogenic shock are really hard. They're pretty much the same thing. But otherwise, when you're in regular shock, whether it's hypovolemic or septic, do you think you're going to have a gallop? No. Do you think you're going to have wet lungs? With the crackles in the lungs? No. Is your heart going to look big on x-ray? No. Your lungs aren't going to look wet on x-ray if you're septic or hypovolemic. That's where you're going to see the differences. Okay, edema. You see edema with these kids? If they're in hypovolemic shock, but if they've been in CHF for a while, you might. So, if you think about it that way, so hepatomegaly, edema, weight gain, ascites, pleural effusions, those are things that I think of with long-term CHF on kids. Okay, you feel for their liver, and instead of being at the border, it's just about down to their toes. I mean, their liver is way down. You'll be able to palpate it. And I put them up here just in case, but as I said, they don't usually stay one-sided or the other. Usually you see the whole thing. So when you're having problems with breathing, they will do a lot more fascinating things than adults can do. We'll see grunting. I shouldn't say see, we'll hear grunting. Has anybody ever heard grunting on a kid? It's at the end of expiration. Okay, not good. Older kids, orthopnea, younger kids, they're just very unhappy. And so what do you think? If I've got an infant with CHF, if I'm not doing a full physical assessment, the parents are going to bring the kid in with the same symptoms as everything else. They're irritable, they don't eat, they cry a lot. That's everything with kids. So it's not until you actually go in there and start examining them that you'll start to see things. Notice I said distended neck veins, good luck seeing that. Think about infants, do you even see a neck vein? You don't, do you? So JVD, things like that, you don't see that on kids. Simply because they just can't visualize it. But you will hear the gallop, you will hear the rails, the crackles in the lungs. Those things, the liver will palpate low. Those things are very easy to see.
What about the periorbital edema?
You can see that, yeah. Again, you have to see, that's a later sign. By the time you see that, they've been there for a while. So if you've got a kid with myocarditis, they could come in with every one of these things on board because, well, they were sick 2 weeks ago and they just never, came back. They never bounced back, and now they're starting to look a little funny. But can you see how a parent would miss it? Because who's thinking these kind of things? Same thing with the new onset, insulin-dependent diabetic kids, the ones that come in with DKA. They never put together that they have the polys. Because this is Texas. They drink and pee all day, all the time. So you're going to find that, you can't really keep track of this stuff until they come in really sick. And then what's happened, the parents are now beating themselves over the head. I still remember the new onset diabetic DKA kid who came in with an a glucose level of 1200. The parents were medical. And they were just wanting to kill themselves. And I'm like, so do you every day look at your children and go, well, they might be getting diabetes. I wonder if they have DKA. Who thinks those kind of things? Nobody does. And remember, it doesn't run in families, right? It's an autoimmune. So you've got to work with these families because they're going to come in and beat themselves up silly. And the blame game is going to happen again. So you sometimes have to put on your black and white striped shirt and bring your whistle, and do time out with the parents because they are going to kill themselves, not kill themselves, but emotionally kill themselves, blaming themselves. Why didn't I see this? Oh my God, it was so obvious now that you're pointing it out. They're not going to see it until they come in. Remember, they compensate for a long time. Okay, so in kids, gee, does this sound familiar? Never heard of it. Now, why do you think they might vomit?
Probably because of all the fluids, they're not able to break
And if they don't have good perfusion, what's one of the places they're not going to get good perfusion? Their gut. So they're going to puke. In the land of cardiac, have you guys heard of PEWS?
Yeah.
Pediatric Early Warning Score? Okay, well, cardiac has their own version. A cardiac pediatric early warning. Some place called CPEWS, some place called CHEWS, whatever. But they have extra points, and one of them is tolerance of food. Because poor perfusion gives them poor tolerance of food. So puking in a cardiac kid is a bad sign. Because it's usually telling us they're not getting perfusion to the gut. No bueno. Gee, here we go again with the poor weight gain. Remember I told you about the diaphoresis, right? They look like they're working out because they're eating. And for them, that's their exercise. And now they have intolerance. In older kids, it's going to be more what you think about with adults. So you're going to see the CHF, they're tired. These are the ones that are definitely going to have the oral edema, swollen feet.
When you say older kids, is there any way you can put an age to that?
I would say in American Heart kind of uses the line of 8 years of age. Because after 8 years of age, all of your organs are functioning at full content. So, you're no longer making more alveoli, your brain is fully formed, your kidneys are functioning. They can start doing myocardial squeeze, on their own after age 8. So that's where you'll start to see these kind of things. And the best classic is everything's white, right? Because the lungs are full of fluid, the heart is blown up. They are definitely scary looking things. Because that's a lot of times what will happen with these cardiac kids that come in with the myocarditis. We give them the fluid and they start to look a little poopy and they do a chest x-ray and it looks like that. And then you're going, bingo, you know what's wrong with this kid. Cardiology, right?
That's a pacemaker, right?
Well, I couldn't find a good one, so leave me alone. It is a pacemaker.
Okay.
There's always a smarty pants in the room, yes. Okay. So the goals are, we want to get their fluid under control so we can improve their function and their output. I think all of these things are kind of duh things, and that they're no different than what you learned in the adult CHF. The difference that you're going to find is in kids, if you always be afraid of a child who doesn't play. That's how you know a kid. Those of you who are parents, isn't that how you knew your kid was sick? They were sitting there. I still remember my first grandson, when he was 1 year old, he came in and had some surgery done. He had an IND, something simple. Post-op, 2 hours, he was in the playroom. Pre-op, he laid in the crib and did nothing because he felt like doo-doo. So that's how you know a kid is getting better. That's why as an ICU nurse, that's why I think I did so bad in Head Start today. I'm a PICU nurse. I like them sedated and paralyzed. I don't want them screaming at me. I want an outline that I can draw my labs out of, so I don't have to sit there and listen to this. You know, and you know, the students are just like, "Oh, this is so much fun," and I'm like, "You guys are crazy," you know? Because the minute the kid was feeling good enough to move around and start crying, they went to the floor because we were done with them. Okay. Okay. All right. So let's talk about Myra. Okay. Some of you guys had number 3 to look at? So Myra Hernandez, 13-year-old, 68 kilo. It's a pretty normal kid, right? Normal weight, normal height. She came into the hospital with a 2-day history of nausea, vomiting. Was admitted for hypovolemia. That sounds like a pretty easy thing. Sounds like she had it, pukes in the poops, right? So they put her on oxygen. They gave her 2 liters of normal saline, which is a significant bolus, but in the land of adults, a fluid bolus is 1 to 2 liters. So it wasn't that outrageous for her age. And shortly after the 2nd liter was infused, she got tachycardic, she got tachypnic, her cap refill went down, her hands and feet had poor perfusion, were cold. They did a chest x-ray that showed a lot like that other one minus the pacemaker. Okay, so cardiology gave the diagnosis of probable dilated cardiomyopathy related to the myocarditis. So now that you know about cardiomyopathy and myocarditis, can you explain why she became very ill after getting the fluid? CHF, yeah, we overloaded her. Right, the supply and demand was in the wrong direction. We gave her too much supply. Knowing what you know about myocarditis and cardiomyopathy, what teaching can you do? What does the family need to know?
Before dental work?
No, this is not endocarditis, this is myocarditis.
She has an infection of her tissue, and that it might be a viral.
So this is the 1/3, 1/3, 1/3, right? That's what we're going to teach her about?
Yeah.
So we're not going to know yet if how long this is going to last, but there's a chance that she might be able to send the cardiologist children to college, just with her monies, right? Okay, Mom wants to know what she did wrong that this happened to her heart. Myra, excuse me. Okay, perfect. Got to get past the blame game. Okay, so how would you explain it to her? She's a teenager. They're very egocentric, right? So, because it's all about me, so I must have done something.
She's got a virus.
Well, they're knowledgeable enough for you to give them a little bit more. What was a viral thing, you know?
Right. Very good.
What's wrong when you got a cold?
Right. Yeah, it can happen to anybody. They didn't do anything wrong. Okay, Myra started on several medications for her condition. So I just came and gave you some generics. An ACE inhibitor, a calcium channel blocker, some DIG, and a diuretic. Can you tell Myra and her family why she's being given these meds? Okay, so why are we giving the ACE inhibitor?
Lower the pressure of the...
Okay, we don't care about her blood pressure probably isn't the problem.
The resistance.
Right, the afterload. We're going to unload it, right? So it doesn't have to work as hard. Because remember, your aortic valve can't open until the pressure inside the left ventricle is higher than the pressure in the aorta. So if we can drop the pressure in the aorta, then the aortic valve, the left ventricle doesn't have to work as hard. Okay, what about, what's the next one on that?
Calcium channel blocker.
It's a vasodilator, and it's it can slow down the heart a little bit, right? DIG, more of the same, right? But increased contractility, right? Diuretic?
Pee it out.
Right, pee it out, you got it. Her echo shows an ejection fraction of 15%. Okay, what's the normal, anybody know what a normal injection?
60, 70.
60 to 75 usually. So 15%. So what do you think is going to happen with her? Okay, for now, we're going to have to really give her a lot of support, right?
Yeah.
Maybe we'll have to put her on something like Milrinone. IV drip, Milrinone, which is a IV inotrope that's going to vasodilate and increase contractility, the two things that you want to get rid of with cardiogenic shock kind of stuff. We also need to let the family know that if that doesn't improve, what might she need?
A new heart.
A new heart, at least a VAD, and then perhaps a new heart. Okay, so once again, we're talking prophylactic antibiotics, just because she really can't tolerate anything more wrong with her. Basketball team. We want to know when she's going to be able to play again.
Not anytime soon.
Not anytime soon. She's going to miss this season. She might make it back for next season if the heart bounces back, if she's in that top third. If she's not, she'll be out of the...
She'll never play again.
Right. She can have the kazoo and the little
Manager.
whatchamacallits. Yeah, manager, there you go. Okay. Is that something you'd want to tell her at this point?
No, never.
Just for right now, it's not in the cards for you. We have to wait and see what happens. Yeah, because especially with kids,
Oh, yeah.
this is, if the team is her entire life,
Oh, yeah.
then we have to worry about suicidal on top of everything else. Okay. Do we need a break before Kawasaki? Just keep going? Alrighty. So by the way, in case you guys haven't watched the Penguin movies, Billy Dance Car, his name is Kawasaki. Okay. And I think we all know motorcycles. So Kawasaki is a syndrome. What does syndrome mean? Right, we haven't a clue what caused it. We just know it's a bunch of symptoms. And that's what Kawasaki is. So it's a group of symptoms, and it says right up there that you look at those symptoms, and they have to have 4 out of the 5 of those symptoms, as well as a high fever for greater than 3 to 5 days. So this comes right from the CDC. Fever greater than 5 days. So a lot of these kids will come into the ER, and they're on antibiotics for possible otitis. The pediatrician put them on antibiotics, thinking they probably have an ear infection, right? Because they give everybody antibiotics.
My son had that, and they thought he had a respiratory infection. So, yeah. We
So they
went
put him
back
on
to
the
ER
antibiotics.
twice.
So then when he came into, what brought him in? Would he walk?
No, my son, he was only 2 months.
Wow, that's an early Kawasaki.
And
They're
we had
usually
every
preschool toddlers.
residential doctor in the room when they had to fly him over to the children's hospital. But yeah, he was only 2 months, and the pediatrician, after we went the second day to the ER, they told us to follow up on Monday with this pediatrician because it was on the weekend, and she recognized the symptoms that he had. This was day 3 by now.
Wow.
And she stepped out and said, let me check something really quick, and came back and said, this is really rare, but I think we need to get you guys to the children's hospital.
Because Kawasaki is usually for, like I said, toddlers, preschoolers. We don't usually see it once they hit school age. So these are the things we're going to see. They never look happy. They have bilateral pink eye that's not infected. They have the strawberry tongue. They have the dried, cracked lips. They have a rash that usually starts in the diaper area and goes up. But the thing that usually will bring them into the ER is they stop walking. And what toddler preschooler doesn't walk? So the parents will bring them in and say, they're not eating, they're not walking, what's wrong? And their hands and feet are swollen and red. Very sad. They're very upset. So they bring them in, we diagnose them, and the reason that this is such a big deal is they can develop aneurysms. And then the redness on the hands and feet will start to peel. And you have to warn the parents it's going to happen because they're going to freak out. They can actually get gangrene on the fingers and toes. It's kind of sad, but it's very rare that you see that. Convalescent phase can take weeks to months. Thing that we always get worried about is these aneurysms. They rarely get them, and now that we have IVIG, they almost never get them. That's what they usually look like, just because they're pretty pictures. Nursing care, try and keep them in bed as long as you can. Give them the IVIG, they're going to give them aspirin. Big amount of aspirin. Okay, 80 to 100, think about it. That would like be giving me a gram, right? No, 10,000, right? Two zeros. Yeah, 10,000 milligrams a day. I'd be getting 10 grams a day. So it's a huge amount. And the reason we give aspirin rather than NSAIDs, we want the blood thinning pot because they can have hypercoagulopathy. Okay? The no-live viruses for 11 months with IVIG, I would know that for NCLEX. That sounds like one of those piddly-diddly little things. Your patient received IVIG for XYZ reason, because they give them for a lot of things. What do you need to make sure the parents understand for discharge teaching? So that's one of those weirdnesses that I would put in the back of your head for NCLEX. Not on this test, but NCLEX. Okay? I think we're going to just go through this super fast because you guys, we're over. So 3 years old, he was admitted for the Kawasaki. Okay? So we know what meds, we've already talked about them. He needs an echo now, and he needs an echo in a few weeks because we're looking for those aneurysms.
Right.
Okay? And it's really hard to get them back in because the kid looks fine, normal, and healthy, but there's that 3 to 10% chance they develop an aneurysm. So we got to get them back in. Okay? He will be better as soon as that IVIG kicks in. So within 6 hours of getting into the hospital, they want to go play. They're back to normal. Okay, rheumatic fever, secondary to strep infections. These are the ones, they have strep throat, and they come back in later with it. Attacks valves. Know your compare and contrast. I promise you there's rheumatic fever questions on your exam. So things I would know. Joint pain, what's another name for joint pain? Arthritis. I can't remember it. I know that word. Yeah.
Joint pain.
Mm-hmm. They also known for having those
Thank you.
with the rheumatic, they get the
Murmurs?
The nodules?
the nodules, thank you, the nodules. It just was not coming to me today. Okay.
Sorry,
Arrhythmias,
what's the one? Sorry.
they can get those nodules.
Oh, the rheumatic fever, okay.
Yeah, they're painless, but they're there at the joints.
Yes.
Okay, pediatric arrhythmias, just remember your numbers are different. Bradycardia is under 100 if they're under the age of 8. The numbers go much higher. SVT is greater than 220. Bet you really want to remember that one. SVT greater than 220. What do we do if they have SVT? We're going to do vagal maneuvers. We're going to have them bear down. If they're too little to understand bear down, we can bend. We'll never do carotid massage. We don't do that on anybody anymore.
Okay.
We can bend the end of a straw and have them blow into it, and it's bent, so they're going to, so it'll make the same kind of thing as bearing down. Might want to remember that one.
A balloon would be more fun.
Hmm?
A balloon would
A
be
balloon
more
would
fun.
be more fun. And if you have that, make them something along that line. But once they're old enough to bear down, that works the best. The reason we don't do carotid massage anymore is because of adults. Because you can break off plaque, and then you'll get rid of the SVT, but now you'll have stroke management.
Yeah.
Okay. We talked a lot about echoes and caths. When we do EKGs on kids, we do 16 leads instead of 12. We do 4 more on the other side, so we get a really good 3D look at their hearts. Education, we've talked about all of this during the day. There's a safe at home program that they do with the really high-risk kids, so the parents are taught how to weigh their kid every day, how to take a blood pressure, how to listen to the heart. Real impressive what they teach them. Since they started doing that, especially with the hypoplas, they're not coming back in dead as much. It's always a good thing. We don't want them to come in dead. Okay, we talked about feeding. If we send them home with tube feeds, we got to teach them how to put them in, right? We got to teach them how to verify position with air, the old way. Talked about meds. We're not going to do this because we don't have time. These are just real quick, test your knowledge. I kind of put at the end. The right answer is in the second slides. We talked about exercise intolerance. These are right out of NCLEX books, okay? So what I do want to get to is the defects, because I don't have the answers there. What defect is this one? Okay, I'll kind of give you a little hint.
It is that P.
PDA, very good. Okay. This one, look at the black line.
ASD.
ASD. Now we'll look where the black line is. VSD. Okay, this is the 4. Right, tetralogy of below. See how skinny? Here's the hole, there's the aorta, here's the fat ventricle. How's that for fast? Okay. How about this?
The HLH?
Nope, that's from the side. Look where the aorta is coming out of. It's coming out of the wrong side. This is that transposition one. Okay. Look at your pulmonary artery aorta. They're together. This is that truncus one. There you go with your little one. There's your HLHS. Look how little that aorta is, huh? Woo. Okay. Thank you for staying over. I apologize for going over.
Thank you for a wonderful lecture.
Thank you.